Sir, please,
Live streaming started. So, Dr. Suman.
Yeah.
क्या बोलते हैं सेना?
Just a second, please.
Good evening, President.
Good
sir.
evening, sir.
Hi, Rekha. Good evening.
Good evening.
hi, Rekha ma'am.
आपल्या
Good
पटेल
evening, everyone.
सर रजनीश पटेल सरांचं नाव बसतंय स्क्रीनवर रॉय पटेल.
Yes, एकदम film
Change करू.
नाही नको राहू दे रॉय सूट्स यू.
नाव आहे एकदम ना रॉय एकदम ते मला एक पिक्चर आली होती.
Nice. Jyoti, my two
We are
younger
live now.
brothers. My two younger brothers call me
Can we
Roy.
start?
Yeah.
Can we start, sir?
Yes.
Yes. It is already.
Okay, so good evening to all respected delegates and faculty members who have joined here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 155th edition of Happy Learning Masterclass webinar series, jointly with Navi Mumbai, Palghar, Raigad, and Sindhudurg Nagari and Thane. The theme for today's webinar is obstetric emergencies. The MOCs for today's webinar are Dr. Suman Sinha and Dr. Asa Jain. Let me introduce them. Dr. Suman Sinha, ma'am is President Ranchi Obgyn Society. She is a senior consultant at AHIVF and Infertility Center Ranchi, Director Advanced Care and Maternity Center Ranchi. Madam is also Vice President SOBSI Bihar. So I welcome Dr. Suman Sinha. Another MOC for today's webinar is Dr. Asa Jain. Madam is Director SMSA Hospital Raipur, Medical Director Cancer Prevention and Relief Society. Madam is elected member of Chhattisgarh Medical Counseling, Vice President IMA Chhattisgarh, and Madam has 32 years of experience. So I welcome Dr. Asa Jain as well. The coordinator for today's webinar are Dr. B. Kalpana and Dr. Jyoti Banglowala. Dr. B. Kalpana is the Post Director for Post Director Fellowship in Endogynecology affiliated to MGR Medical University. Ma'am is National Coordinator for Infertility Committee FOXI, Chairperson Infertility Committee TNFOG, Secretary for MOPS. I welcome Dr. B. Kalpana. Another coordinator for today's webinar is Dr. Jyoti Banglowala. Ma'am has 26 years of experience. Madam is Vice President Indore Obgyn Society 2022 present, Secretary Indore Obs and Gynec Society 2021 to 2022. And Madam is interested in ethical and medical legal aspect of Obs and Gyn. And Madam has also received various awards from Indore and MP government. So I welcome Dr. Jyoti Banglowala as well. And as per the traditional course, I would like to start the session with lamp lighting ceremony.
Poor society. madam.
No sound coming.
E-lamp.
Okay. But there must be some sound now.
Volume बढ़ाओ, volume. नहीं बढ़ा.
So now with this, I hand over the session with Dr. Suman Sinha and Dr. Asa Jain, who are the MOC for today's webinar. So over to you.
Okay, can you hear me now?
Yes.
Yes, madam.
So thank you, Nilesh ji. Good evening, everybody.
Yes.
After invoking blessings from the deities and our seniors, we move on to the inaugural function. And for this, I, Dr. Suman Sinha and Dr. Asa Jain, MOC of Happy Learning, take the honor to welcome all the dignitaries and our esteemed guests in the 154th fifth episode of Happy Learning Masterclass webinar series in association with Navi Mumbai, Palghar, Raigad, Sindhu, Durgnagri, and Thane societies. And our theme of today's webinar is obstetrical emergencies. This program has been conceived by our program director, ex-Vice President Foxy, and a very eminent medical legal expert, Dr. MC Patel, sir, with the idea to spread knowledge to the last Foxian. His mission and strong dedication has brought us today to the 155th episode, which is an incredible journey, and we have all applause for it. And now I welcome our honorable chief guest, Dr. Uday Thanawala, sir, ex-chairperson ICOG. And then next I welcome our revered guest of honor, Dr. Prakash Patil, sir. I welcome our program director, Dr. MC Patel, sir, the conveners, Dr. Sneha Buyar, and Dr. Supriya Arwari, all the luminary speakers, moderators, chairpersons, and panelists for very meticulously preparing the subjects to upgrade us with the recent advances in obstetrics and gynae. I welcome our team, Happy Learning, for their efforts. And lastly, I welcome all the president and secretaries of all societies who have joined us today. And then I also welcome our academic partner from Corona for giving us all the logistics and also providing us this digital platform. So again, welcome everyone. And I take the opportunity to invite our director, Dr. MC Patel, sir, for his welcome address.
Thank you, Suman, for kind words. It gives me immense pleasure to welcome you all on 155th episode of Happy Learning Masterclass web series, and joining society in Navi Mumbai, Palghar, Raigad, Sindhu, Durgnagri, and Thane. I welcome Dr. Uday Thanawala, who has kindly consented to be chief guest to bless the webinar. Of course, Uday is always with us in any of our academic activity. So welcome, Uday. I also welcome Dr. Prakash Patil from Raigad. He has kindly consented to be guest of honor to bless the webinar. Of course, Prakash Patil sir is also always with us in any of our academic activity. I also welcome two learned speakers, Dr. Bharti More from Navi Mumbai and Dr. Rajneesh Patel from Thane. Both are going to discuss very important topic for today's discussion as far as obstetric injuries are concerned. I also welcome two learned moderator, Dr. Supriya Arwari from Thane and Dr. Deepa Kala from Navi Mumbai. They are going to discuss very interesting cases during panel discussion as a moderator. I also welcome two learned expert panelists, Dr. Sneha Buyar from Yavatmal and Dr. Rekha Rajendra Kumar from Bengaluru. They are going to put their expert comments at the time of panel. I also welcome all the panelists, Dr. Bharti Rajshekhar from Hassan, Dr. Jainarayan Senapati from Thane, Dr. Nageshwari Nanda Madam from Thane, Dr. Swarupa Iyer from Thane, Dr. Sailendra Yadav from Thane, Dr. Madhumati Deb from Navi Mumbai, Dr. Kranti Phadnis from Navi Mumbai, Dr. Santosh Jaibai from Navi Mumbai, and Dr. Kavita Barnwal from Bhagalpur. I also welcome all the learned chairpersons who have consented to chair respective session. Dr. Rekha Thote from Thane, Dr. Anu Bij Madam from Navi Mumbai, Dr. Sonali Sete from Raigad, Dr. Ujwala Bardhanpurkar from Thane, Dr. Nina Dhar Madam from Navi Mumbai, Dr. Sandhya Sarhan from Navi Mumbai, Dr. Girish Sawant from Navi Mumbai, Dr. Bala Sahib from Navi Mumbai, and Dr. Jyoti Bube from Navi Mumbai. I also welcome again Supriya Arwari as a convener and with Dr. Sneha Buyar. And I put it on record all the help and support extended to us for this webinar by Dr. Supriya Arwari. So thank you, Supriya, for the same. And I also welcome two learned coordinator, Dr. B. Kalpana from Madurai and Dr. Jyoti Banglowala from Indore. So Sneha, B. Kalpana, Jyoti Banglowala, Asha Jain and Suman Sinha They all are with this series since long and doing very marvelous work. As far as today's MOCs are concerned, Dr. Asha Jain from Raipur and Dr. Suman Sinha from Ranchi, they are going to be master of ceremony for today's webinar. So today's topic we have very aptly decided to discuss obstetric injury and obstetric emergencies in our day-to-day practice. And we know these are the areas as far as litigation part is concerned, because many times we have not counseled patient properly and something goes wrong as far as any obstetric injuries are concerned, it becomes a potential area and they may end into litigation. So how not to end up into litigation, and if at all we ended, then how to get rid of it is the motto to discuss this type of problem, this type of topics in our series. Ultimate goal is to be helpful to our Foxian friends to update their knowledge, and ultimate goal to check maternal and infant mortality, because by 2030, WHO and central government has given us a target that maternal mortality should be less than 67 and infant mortality should be less than 12. Of course, there are so many states in southern India, they are near 30, but at the same time, there are few states in UP and particularly in northern eastern area where still they are having maternal mortality near 200. So it is a joint venture on part of government, NGOs, organizations like IMA, Foxy, and obstetrician friends, and particularly who are working in remote area. So if we go join hand, then we can check this maternal mortality and infant mortality also. So with this aim, we are discussing focus topic. So welcoming you all and all the president and secretary of joining society, Navi Mumbai, Palghar, Raigad, Sindhudurg Nagari, and Thane, and all the delegates who have joined this webinar. Again, I welcome you all. Thank you very much.
Thank you, Patel sir, for your official address. And now I take the opportunity to invite and welcome our series convener, Dr. Sneha Bhgar Madam, for her address. Can I have Madam CV?
Dr. Suman, she isn't here.
Okay. So,
She
Dr.
isn't
Asam,
here.
take the opportunity to introduce Dr. Supriya Arwari.
Yeah, so next slide. Next slide.
Supriya,
May I
join.
have Dr. Supriya's CV, please? Vasu?
Nilesh,
Nilesh ji,
Nilesh,
where
Yes,
is
sir.
it?
Yes, sir.
yes.
Just the next one.
CV of Dr. Supriya.
It's okay, ma'am.
No, I would
Yes.
really
Supriya is
like to
known.
introduce a very laughing Supriya.
Dynamic Supriya.
Supriya doesn't
Dynamic-
require any
no, she's
introduction.
always laughing. Always.
Always,
happy.
Thank you.
always. Ever smiling. Yes.
So it's
And
happy
Supriya is known
Supriya.
worldwide, madam.
So
Madam known in the universe.
Don't say that on the moon.
I think we should proceed, madam. Please go
ठीक है,
ahead.
ठीक है.
So then you have to say a few
just a
words.
second.
You are the convener of this program
With a share.
along with Dr. Sneha. So
एक शेर सुनाते हैं.
एक शेर सुना
a
दो.
few words.
शेर तो बनता है.
सुप्रिया जब तक एक शेर सुना दो.
नहीं सुप्रिया शेर बोले, इसके लिए मैं सुप्रिया के लिए शेर बोलूंगा.
अरे
क्या
वाह.
बात है.
वाह, वाह, वाह.
बोलिए,
क्या बात
बोलिए,
है.
sir.
क्या बात है, sir? So nice.
Whenever we call Supriya, she is always ready to help any of our academic activity. But Supriya always say, अगर नापना चाहते हो मेरी उड़ान को, अगर नापना चाहते हो मेरी उड़ान को, कह दो आसमां को थोड़ा और ऊंचा हो.
ऊपर जाओ.
वाह,
क्या
वाह,
बात
क्या
है.
बात है.
क्या
Very
बात
nice,
है.
sir. Very nice.
क्या बात
बहुत
है.
सुंदर.
Perhaps she deserves.
Perfectly
For
said.
Supriya.
Very apt. Very apt.
Very
So,
apt for Supriya.
I think we need to remove the CV.
Yeah.
Dr. Supriya, a few words from you.
Yes, Supriya.
And
Actually, yeah, I actually, Dr. MC Patel has, spoken most of what needs to be said. So I take this opportunity to invite everybody. I can see Dr. Uday Thanawala, my dear friend, ICOG boss, Dr. MC Patel, and Dr. Rajneesh Patel is here. All senior people, Asha ma'am, Suman ma'am, Dr. Senapati, our president, has joined in. I can see Dr. Prakash Patel. Hi, sir. And
Hi.
all my dear friends, Shailendra, Swarupa, Rekha, Santosh, hi there. Hi, Jyoti, Sonali. Welcome, everybody. Hi, Kalpana, ma'am. Very busy you must be for your VP conference. So I take this opportunity to invite all our, the people who are in the audience for an academic feast and a very well-selected subject, that is labor room emergencies, perennial tears, and all medical legal aspect also related to it. So I think it's going to be a fantastic session, academic session, and I invite all of you to please hang on and listen to all that is to be deliberated today. Thank you so much.
Thank you, Supriya.
Thank you, Supriya. All the help
MC
you have.
पटेल सर ने इतना
Yes.
सुंदर शेर सुनाया तो एक शेर मैं भी उनको डेडिकेट
बिल्कुल,
करना चाहूंगी.
बनता ही है, बनता ही है.
Welcome.
सर, सपने उन्हीं के सच होते हैं, सपने उन्हीं के सच होते हैं जिनके सपनों में जान होती है.
वाह,
पंखों से कुछ नहीं होता, हौसलों से उड़ान होती है.
very good.
So all the best to
बात
you
है.
also for your endeavor.
क्या बात है.
Yes,
मैं
welcome.
तो बोलता हूँ ये सीएम भी छोड़ो, मुशायरा चालू कर देते हैं.
Not a bad idea.
तो शैलेंद्र हो जाए एक आपकी ओर से भी.
अरे सर हमें किधर आता है, हम तो बस सुप्रिया की छत्र छाया में पले
वही
पड़े हैं
तो.
सर.
और सुप्रिया हो और शेर ना हो तो हो ही नहीं सकता.
Yes, sir.
Thank
So
you.
back to you, ma'am, Suman ma'am.
Yeah, thank you, Supriya, for making all of us laugh, making it a very enjoyable session. And now I invite Dr. Asha to introduce our chief guest and take his blessings.
May I have the CV of Uday, sir?
Yes.
So it's a great privilege to introduce our chief guest of the evening, Dr. Uday Thanawala, who's a consultant obstetrician and gynecologist at Navi Mumbai. He's the immediate past chairman, ICOG, and vice president, FOGSI in the year 2015, treasurer, PCOS Society of India, chairperson, Medical Disorders of Pregnancy Committee of FOGSI in 2006 to 2008. Founder Secretary, past President, Navi Mumbai Obstetric Gynec Society, Joint Secretary, FOGSI 2005.
Yeah.
Very accomplished
Thank you.
academically, and we all remember him for his in the ICOG conference. So welcome, sir. We would really love to hear words of blessings for you for this webinar.
Thank you so much, Asha. Thank you for having me here, all of you. And thank you, Dr. MC Patel. And I must say this to Dr. MC Patel, that this, I remember the time when we were in the midst of Corona and you had started the Happy Learning series. I was there at that time also, and it was amazing that the way, the passion by which you are carrying it forward. I can admire the minuteness of detail which has been taken care by you and your full team, Jyoti, Supriya, Kalpana, everyone, Suman. Amazing, and kudos to you for doing this so well and doing it on, and you are doing and bringing such interesting topics, because when you talk of perennial injuries, whatever you say, you counsel the patient, normal delivery hoga. Nowadays, we Indians probably even say, okay, now we will give you episiotomy also. Abroad, we are not supposed to give an episiotomy unless you have a separate consent for episiotomy. Second or third degree tear bhi ho jayega. And if it happens and if it doesn't heal properly, the problems which can arise, and I'm sure today you're going to shed light on that with these wonderful lectures which are lined up. So thank you so much for choosing these sort of topics which affect the common obstetrician and gynecologist. And another thing, when you talk about medical legal aspects of things, when you are having, like most of us in these 3-4 societies which have joined together, most of us have small nursing homes or medium-sized nursing homes, etc. How do you keep tab that your paperwork is perfect? Now, we are lucky to have Rahul Vani and Santosh Jaib here who are medical legal experts. And I asked Rahul, you please come and audit my nursing home. So he actually comes, spends 2 to 3 days in going through each and everything what we have done. And he tells us these are the deficiencies. So one appeal to all of you is, in Thane, in all the societies we've joined in, is get your nursing homes and get your practice audited by these medical legal experts. There will be 100% deficiencies which you will have to, fill up, and they will draw your attention to that. We all feel, hum log to sab theek kar rahe hain. But ultimately, when somebody has a look, a medical legal expert has a look and points out the deficiencies to you, it's so much more easier and better and much more safer in today's practice for all of us. So it's great to be a part of this webinar. Thank you so much for having me here. I'm not going to name everybody here because they've been named several times anyway, but I really thank you and wish you all the success for this webinar. And another messages that Bharati has called up and said the internet connection was not good at her house. So she has gone to the hospital. She'll be reaching in 10 minutes, but she's asked the other speaker to speak first. She will speak next. Thank you very much. And let's get along with the webinar. Thanks.
Thank you, Uday, for sparing time. Of course, you are always with me in any of my academic activity. So thank you very much for sparing time.
Thank you, Uday sir, for your enlightening words and making us aware about the medical legal issues which must be in our clinics and nursing homes. Thank you for your precious words also. And thank you, Mr. Patel sir, for your inputs. And now I take the delightful opportunity to introduce our guest of honor, Dr. Prakash Patil sir. So I need the CV. Yeah. So regarding his designation, he owns a nursing home named as Lifeline IVF Center, and he is consultant gynecologist, a video endoscopic surgeon, infertility and IVF specialist, and he is practicing in Panvel, Navi Mumbai. He is chairman and managing director of Lifeline Multi-Super Speciality Tertiary Care Hospital, Panvel, and director of the same center. He is the founder president of Raigad Obstetric and Gynecological Society, member of managing committee of ISTAR, member of managing committee of Association of Medical Consultants, member of managing committee of IAGE, and he is the chairman of Maharashtra chapter of IAGE also.
I think it's enough. I think we'll
Sir, 1 minute, sir. 1 minute, sir. There are so many awards and achievements.
It's okay. It's okay.
He has been awarded by Government of Maharashtra for Best Work in Family Planning for performing more than 45,000 laparoscopic tubal ligations. He has been awarded by a prestigious award, Kanushri Patanjali Puraskar Award in 2007. He is awarded for Lifeline IVF Center for the best of the best IVF centers in India. Great, sir. And he owns the Lifeline Hospital. Panvel is awarded with Corporate Excellence Award in 2014, Global Healthcare Excellence Award among Best Multi-Speciality Hospital, Mumbai. So there are so many awards and accolades to sir. And I request you to address our gathering.
Thank you, Suman. Thank you for those kind words. And I really take opportunity to thank to our program director, Dr. MC Patel sir. And I welcome to all the speakers, then the chairpersons, coordinators, everybody, because there is a lot of time. We are supposed to go for the subject. Once again, thank you very much, especially to Dr. MC Patel sir and Dr. Uday Thanawala. There are so many senior are also there whom I can see here. But once again, just regarding what Uday said is very right, that you are supposed to update yourself medico-legally, particularly when we are running a 250-bedded hospital and we are a tertiary center for obstetric emergencies. Many times the obstetric emergencies are referred from all over district to us because we are having a ICU and a backup of ICU, blood bank and everything. So mostly we are having obstetric emergencies, particularly PPH and all that, in which we are doing the embolization, because we are having a cath lab, internal iliac artery and all that. So such type of emergencies we are handling, but at the same time, we are very happy to have a task force in Panvel. Every time when there is an emergency, this task force of at least 5 to 10 senior people, they go to the hospital. Everybody sees the patient as well as the relatives, as well as the paper, the case notes. One or two people are there. Dr. Shete is there, who is very particular about looking after the paper and completion of the paper, because there you lag behind many times in the courts. So, dear friends, everybody nowadays, Dr. MC Patel, we should thank to Dr. MC Patel that he has started such a good, excellent webinar series of obstetric emergencies, and we should really thank to him for his inputs. Once again, thank you very much, all of you, for giving me this opportunity to be a guest of honor. Thank you once again. Please. Thank you so much.
Thank you, Prakash Bhau. You have rightly mentioned about this RUST team. When I was Vice President Foxy in 2018, I had taken this task that each and every society should have RUST team. RUST team for surgical assistance in any given situation. Say, for example, you have rightly mentioned if it is a case of PPH and internal iliac artery ligation is needed, but one is not well versed with internal iliac artery ligation. So, member of RUST team who is well versed with this surgical excellence, they can go to the hospital and assist him in this given situation. At the time of declaring bad news, it is also one more area. At the time of mob violence and in case of litigation. So this RUST team, member of RUST team will be useful and helpful to the member in any given situation. So you have rightly mentioned this type of team is always very useful to our Foxian friends. Thank you.
Sir, many times, I'm sorry to say, I will just add one thing.
Yes.
We are having a cath lab. So we prophylactically put balloon in the internal iliac arteries and operate the patient. So the mortality is less.
Reduce.
Like that.
So
Thank you, sir.
ultimate goal is to take not only care of patient only,
Yes.
but care of ourselves also.
Yes.
Situation not to enter.
Absolutely.
And records are always at your risk. So if you have a maintained record, whatever you have done for the patient, because ultimately it shows your concern to save life of patient. And if you can show it from your record, then it is always better, and very nicely mentioned by Dr. Uday also. So our Foxian friends and who are in this medical legal practice, they are always there to assist you in any given situation, including me.
Okay, sir. Thank you, sir.
Thank you, Prakash Patil sir and MC Patel sir, for your enlightening and encouraging words to all of us. And with this, we come to the end of the inaugural function, and we'll be quickly moving for the academic. And I thank our chief guest, Dr. Uday Thanawala sir, our guest of honor, Dr. Prakash Patil sir, all the conveners, all my team, Happy Learning, all the presidents and secretaries of societies who have joined, our luminary speakers, chairpersons, moderators, and panelists for joining us today and gracing the occasion. So I pass over my baton to Dr. Jyoti Banglawala and Dr. Kalpana for the academic sessions. So thank you all. Thank you all for wonderful our inaugural function.
Suman, actually, it is my privilege to be a part of this wonderful series, that to 155th edition, organized by our program director, MC Patel sir. And this program has been designed by our dynamic Supriya Adwari ma'am and also Sneha Boya ma'am. We got blessings from Uday Thanawala sir, who is a very humble person, occupied prestigious post, past ICUG chair, ready to share his views at any time. And also he has told valid point. All our hospitals have auditing for finance department. This is a new point he has brought out. Every hospital should have medical legal expert, and the document should be audited very frequently by our medical legal experts. So our MC Patel sir can help any of the gynecologists who are in need of this kind of audits. Anyway, we all know that prevention is always better than cure. So we got, thank you, Uday sir, for your blessings. And we also got our blessings from guest of honor, Prakash sir, who had told that we should have task force, which has been implemented by our program director during his tenure as a vice president of FOMC. Thank you, sir, for your blessings. With your blessings, we move on to the next session, perineal tear, which is really difficult to treat. And I invite the chairpersons, Dr. Rekha Thotet, who is an advanced endoscopic surgeon, having mobile endoscopic unit attached to various hospitals in Thane, high-risk obstetrician and gynecologist in Thane, medical director, Shri Clinic, co-head of OCCU Kure Group of Hospital, honorary laparoscopic consultant, Family Planning Association of India, Thane, vice president, Thane Uji Society, recipient of Mrs. Intellectual title in International Beauty pageant held in Moscow, recipient of Thane's prestigious Navdurga Award. Welcome, ma'am.
Thank you.
Our next chairperson is Dr. Anu Vij, who is an obstetrician and gynecologist for almost 24 years, and she has been trained in best hospitals of Mumbai. She has got special interest in high-risk obstetrics, fetal medicine, sexual medicine, urogynecology, preventive oncology, infertility. And Madam has got fellowship in sling surgeries, training in sexual medicine, colposcopy hands-on training from Pune, ultrasound training, and IUI hands-on workshop. Welcome, ma'am. Our next chairperson is Dr. Sonali Shetty, who is a consultant and fertility consultant, gynecologist, obstetrician, director, Mauli Nursing Home, in various hospitals in Thane. Madam's interest is high-risk obstetrics. Welcome, ma'am. Rekha ma'am, can you please introduce our speaker? Anu ma'am can give an intro about the topic, and Sonali ma'am can conclude once the talk is over. Over to you, Chairperson.
Sure. Thank you, Dr. Kalpana, for nice, kind introduction. At the outset, I would like to thank Dr. MC Patel for giving me an opportunity for chairing this session. So our first speaker is Dr. Bharati More. Dr. Bharati More is an MBBS and MD gynecologist. Done yes. She has done 5 house job in OBGYN, 1 house job in anesthesia, post-MD registrar in OBGYN. She has done an MD in OBGYN in December 89. Full-time gynecologist at Sant Radhika Bai Meghe Trust Memorial Hospital. She is an honorary gynecologist and honorary gynecologist.
Rekha, can I interfere?
Yes, please.
Rekha, just consultant in OBGYN since 1990 and past president Navi Mumbai Society. That's enough, I suppose.
Okay. So consultant gynecologist and past president of Navi Mumbai. Welcome, madam. Over to you.
Thank you. At the outset, good evening, everybody. Sorry for the delay. There were some technical issues for internet at my house, and that's why I rushed at the hospital. I'm starting screen sharing.
1 minute, ma'am. Anu, ma'am. Do we have Anu, ma'am, here? Ma'am, your views to start the session. Anu, ma'am.
Can you hear me?
Yes, ma'am. Yes, ma'am.
Good evening, Anu.
Hi, Bharti. Nice to see you. And I'm proud that you are starting the first talk of the session.
Thank
Good
you so
evening,
much.
everyone. And it's a real pleasure seeing everyone together on the same platform. And before I begin, I would like to thank the organizers as well as Dr. Patel, sir, for including this all-important topic in his lecture series. So as long as we all are prepared to have normal deliveries, we are going to face this dilemma of perineal tear and obstetric injuries to the anal sphincter. So since the topic is very important, they have rightly selected the candidate to talk on it. Bharti, with such a long experience and good obstetric practice, is the right persons to talk about it. And I'm sure she's going to include how to prevent, how to recognize, how to do the first-hand repair, and how to escape the litigations. Over to you, Bharti.
Thank you so much, Jyoti. Thank you so much, Anu, for those kind words and the faith that you have in me. Thanks a lot. And at the outset, I would first of all apologize for being late because of some internet connections at home. I'm in the hospital now. Respected MC Patel, sir, and Rajnish Patel, sir. Of course, my friend Dr. Prakash Patel is there. Thank you, Jyoti Manglowala, and my chairperson, Tote Madam. With that, I think I'll start my talk. Friends, perineal tear is a very common injury that all of us as obstetricians face. We are all hardcore obstetricians, and of course, we believe in normal deliveries, though the cesarean rates have increased. And therefore, I think even when we did the house jobs and then with the registrars and the lecturers, we have always, tried and learned not to make perineal tears. First of all, prevent them. And if at all it happens, when the patient comes fully dilated with head-on perineum, how to take care of them once they have occurred. So, per rectum examination after every delivery is a must. I start with that. And then I think none of us will miss the perineal tears. The subject, what all I'll be covering is, first is diagnosis, then repair, identification, whether it is first, second, third, or fourth, and how do you prevent them, and the pregnancy after the third and fourth tears. That is how I'm going to go. So the incidence of what is perineal tear? Perineal tear is basically when the baby is delivering, the skin, the labial skin gets torn off, and then you have the subcutaneous tissue, the fat, and then other muscles that are surrounding the vulva. I mean the os from where the vagina where the baby's head comes out. So second degree trauma occurs in almost 16 to 90%, and the third and fourth degree is almost 1 in 100. That's 0.1%, very less. But if you do an endoanal ultrasound, and then you see that the incidence goes up to 40%. First degree involves the fourche, the perineal skin, as I have started, posterior vaginal wall. Second degree involves the above structures as well as the muscles of the perineal body, but it still doesn't involve the external anal sphincter. So these are called the first and the second degree, or the incomplete perineal tears. Once your external anal sphincter is involved, then it becomes a third degree perineal tear. And once when the anterior wall of the rectum is open, it becomes a fourth degree perineal tear. First and second, I think we're used to it. So if you give a liberal episiotomy where all it is indicated, I think we can avoid all these things. But then nowadays, the things are that don't give episiotomy. Give it only if it is required in your instrumental deliveries. So the topic of perineal tear becomes a topic of importance. This is something about the anatomy of the area where you see the bulbocavernosus muscles first surrounding the vaginal wall. Then you have the transverse perineal muscles and the bulborectalis muscles, which are surrounding the anus. The external anal sphincter is also seen well there, which is the connection between the vagina and the anus. So what are the risk factors which are responsible? The preemie patient, if she has the expected baby weight is more than 3.5 kg, and she's not very well built. Prolonged second stage of labor, when the preemie is trying to push the head of the baby down for more than 2 hours, and then yet she's not delivered. Instrumental deliveries such as forceps, if not applied properly. Heavy birth weight, as I told you, occipito posterior positions. Inadvertent use of pitocin. epidural anesthesia, where the patient sometimes is not able to bear because of the anesthesia effect. And if there's a shoulder dystocia and the obstetrician is, she's frantically trying to deliver the baby with all the maneuvers. So these are the few causes which are responsible for the perineal trauma. At times, most of the time, it is that your assistant is not giving a proper perineal support, that there are the tears which are happening. And of course, there's a precipitate labor which comes in, which you can't help it. Patient, till the last stage, she stays at home and finally she comes as an emergency with head-on perineum. And we don't have time even to wear gloves. And then she delivers without assisting. So these are a few causes which are responsible for the perineal tears. How you diagnose it? Diagnose it, and that's why I started my talk with saying that everybody should be in the habit of doing a PR. Even if she's a primary multi, do a PR and confirm that it is the wall between the two, that is the vagina and the rectum, is intact. Once that is done, then if at all it is an injury, you see what it is, like whether it is a first, second, third, or the whole of the anus is through and through open, the whole compartment, the whole wall is broken, then it becomes a 4th degree perineal tear. So you might require anesthesia, you might require block, good light exposure, and then most important thing is the repair. Now, there are many people who allow the assistants to deliver, but more of us who believe in delivering the babies themselves. So the suturing has to be done within 6 hours, because if you delay the suturing beyond this, probably your chances of not having a successful suturing is high, and therefore the repair should be taken as soon as possible. That's ASAP. It's an obstetric emergency, although the patient is hemodynamically stable. So what you use, you normally use 30-Vicryl and not PDS for the inner mucosa. Use continuous suturing for all layers, not interrupted. Bury the knots and warn the woman about how long the suture may be present. You can do it in the labor room as well. No need of going to the operation theater. And you can do it under local anesthesia or a block. You can use 20-Vicryl, but I would prefer 30-Vicryl. Or you can do it with 30-monofilament PDS for sphincter repair, if it is there. Most important thing is the post-op care, which I'm going to talk. Here, this is just a photo picture of end-to-end repair we can do, or we can do an overlap repair. The most important is the post-operative care, which is important. That is, of course, antibiotics have to be given IV. Perineal, I normally put a rectal suppository or pessary, which is the painkiller, every 8 hourly. We give them a perineal care where you, you sort of clean it, apply the cream, betadine or metronidazole, whatever you have, and we give the, like good old days in Sion also used to give, and we give them phototherapy. We have that, where you use that lamp and then you give them phototherapy for at least 10-15 minutes, and we give this 8 hourly. You use broad spectrum antibiotics with metronidazole. Laxatives have to be given to the patient immediately, and tell them about the diet, where she should have a semi-soft diet on day 1, so that she passes stools without straining. Of course, you can tell her about some physiology, some exercises, that's physio, some pelvic floor exercises. Normally, I tell them Kegels exercises, which all of us know. And you have to assess the symptoms on daily basis. I would like to keep this patient in the ward for a couple of days more. Like normally, when there's no epi-PT, we discharge within 24 hours. If there's a PT-epi, we discharge on the 3rd day. I would keep this patient for 1 more day and discharge her after she's passed proper stools. At home also, I would advise her to take a semi-soft diet, to take a laxative, not to strain for passing stools, and be on a high roughage diet with plenty of fluids, and no intercourse for a few days, at least for a month or so. So the importance is some of the patients might need a ultrasound, which has to be done per rectally, and see whether the healing has been proper or not. So evaluation of symptoms, you see whether she can pass the flatus properly, any incontinence of liquid or solid stool post-operatively, and therefore whether she needs to wear a pad, or any fecal if she has a fecal urgency, that's inability to defer defecation for more than 5 minutes, all the symptoms have to be, told them. And depending on that, you give them a scale that is 0, 1, 2, 3, 4. 0 implies that she is complete continence, that is, she is completely well. If it is a score of 20, that means the operation has failed, and therefore you might need to re-intervene again, and maybe she'll need a second repair. So a cutoff of 6 is taken. Below 6, I think there's no need of repair, but after 6, you need to evaluate her again with the endorectal sonography. So most important, don't allow any vaginal infection to occur. And I think I have covered this. That is, the vagina is separated from the rectum. The torn end of the external sphincter is identified. First, you do the anal mucosa, and then once you do it down, you can come towards the vagina, doing a end-to-end anastomosis or overlapping anastomosis, and then you come to the skin. Post-operative, I told you. And most important is, how are you going to avoid the obstetric injuries? Avoiding is, most important thing is I would give a liberal episiotomy where you feel the predisposing factors for the perineal tear are there, which I already told you, where she's a occipital posterior, or the baby is heavyweight, or she is a thin limb patient, maybe, or maybe you feel that there's a long time, or there's a intervention of instrumentation, that you're applying forceps or vacuum, then I would give a liberal episiotomy rather than going for a perineal tear, which is not in our hands because the first, second go in third or fourth. So I am for episiotomy, but today's teaching, they say that routine episiotomy is not recommended for spontaneous birth. It should be given only after proper clinical decision has been taken by the proper clinician. So with that, I think what sort of episiotomy is not the topic of my discussion, so I should not go into the details of. So birth after previous third and fourth degree trauma, what they say that if the patient is a repair done of fourth degree, that is anal mucosa was taken up and through tear she has, and now fourth degree perineal tear has been repaired and she's completely continent, that is, no incontinence of her rectal incontinence is not there, then in such cases, it is better to go for a planned cesarean section, then taking the test of allowing her to go for a normal labor and giving the risk of, again, a fourth degree perineal tear. So what are the nice recommendations for the care of patients with previous third and fourth degree trauma? What they say is that whatever I've already said, routine episiotomy, again, they say that depends on the decision of what has been, I've already spoken of. So this is again the schematic diagram of the muscles which are involved: bulbocavernosus, transverse perineal muscles, internal sphincter, and then the external sphincter, and then the internal sphincter, and then the rectal mucosa. Again, these are the few pictures which make things very clear. With that, I think I'll end my talk. Thank you so much. Again, I thank both the Navi Mumbai Society as well as the Thane OB/GYN Society, Dr. Patel sir and Dr. Sneha Bhuyar for initiating this online program. Thank you so much.
Thank you, Bharti Madam, for such a great academical and evidence and experience-based talk today. I am sure everyone must have faced some or the other problem of perineal tears in their practice, and Bharti Madam has precisely taught and guided us for the prevention and treatment for the same, so that we can put everything in our practical day-to-day practice. Thank you, ma'am.
Thank you so much. Thank you.
With this, I conclude the first session of perineal tear.
Can I say a few words about episiotomy?
Yes, sure.
I think Bharti has done a very good presentation, and at the start we heard Uday speaking about RCOG guidelines about the episiotomy being not a mandatory event in today's OB/GYN practice. But I still would recommend my good old days in Vadia, where episiotomy is a part and parcel of the normal vaginal delivery definition. In our days, we were taught that episiotomy is a part and parcel of the normal vaginal delivery. And I think we better stick to it. It's better to give an episiotomy and a liberal one at that, rather than having a second, third, fourth degree perineal tears
Yes,
and sit in
I
repairing it.
agree. I agree.
So I mean, whatever RCOG may say, may God bless UK, but otherwise, I think we better stick to our own Indian standards.
Thank you. Thank you, sir.
Yeah, thanks, Bharti.
Thank you, sir. Do we have any more discussions or remarks from the seniors?
I think Bharti has finished way ahead of her time.
Topic was very small.
Yeah, and that will be a tough act for me to follow.
Your topic is vast.
The only thing I can add to this is I have actually done a research paper published on episiotomy. It's something known as epi-scissors, which was devised by one of my colleagues in the UK. And the basis of that was that when the head is fully dilating the perineum, what we think is we are giving a 45-degree cut, is we are giving a 45-degree cut on an enlarged ball. When that ball collapses, you realize that it is a 15-degree cut or it's a 20-degree cut. You understand my point? So if you want a 60, what they say is a 40 to 60-degree episiotomy cut is the safest. That 40 to 60 degrees should be after the birth of the baby, it should be 40 to 60 degrees.
Agreed.
So I would, any of the juniors who are logged in, I would advise them to err more on the side of medial episiotomy.
Medial episiotomy.
Lateral. More towards the lateral side when the perineum is fully dilated.
Fully dilated.
You go more towards the 90 degrees.
More toward 90 degrees, yes. So that after this thing, it collapses to 45 degrees.
When the perineum comes back to its original level, you will get a 45-degree or a 60-degree episiotomy.
That's a very, very good practical suggestion.
You mean to say, sir, normally we give a 4 o'clock position, right?
No,
so what sir said between 3 and 4?
Between 3 and 4.
Between 3 and 4.
Okay, okay.
And one more point.
Yes,
When we admit a patient for a safe delivery, it is always advisable to take a consent for episiotomy beforehand. Whether you give or not is your choice.
True.
Or how the
Absolutely.
situation
Truly said,
calls.
Anu.
So it
Truly
has to be taken in black and white at the time of admission itself.
Right. Thank you, Anu, for adding that medically.
Bharti, it was a really excellent lecture. No
Thank
doubt.
you.
Very valuable inputs. I just wanted to highlight one thing. Between the 3rd degree and 4th degree tear, there is a thin line. So
Yep.
in such conditions, many times it happens that the patient is not cooperative, and we may miss the 4th degree anal mucosa tear, which is high up, and we suture it low down, and later on the patient reports
RVF.
with the fistula.
With RVF.
So in such condition, I think proper exploration of the tear should be done.
Under good spinal anesthesia.
Yeah.
Absolutely. Spinal or
required.
whatever is required.
Spinal
but
or
proper, as in when you suspect 1% of 4th degree tear and the patient is not cooperating, in such condition, a proper exploration of the tear should be done to avoid the future these fistulas and all that. I think that is very.
I would also go ahead and say that if required, call a general surgeon friend of yours, for help. If
not required, madam.
Unless
Bharti, madam, not
I
required.
have done. See,
Nowadays,
we have done it. We only do it, sir. Not that we don't do, but medical legally it is better that
No, there is no medical legal aspect in this. You can very well do it. Don't worry. I'm sorry to say, even general surgeons are lost at this field. Many times.
But on paper, general surgeon should be there.
No, sir. Patil, sir, not required. Not required. Not required. 2 gynecologists, all the
An
legal things.
obstetrician is better trained to deal with these tears than the general surgeon.
I would agree with madam.
Elendra, at least one
I
more
fully
gynecologist
agree with
has to
that.
be there.
They
One
have
more
more
gynecologist,
experience,
two
more
gynecs.
training.
Agreed. So one more gynecologist at least has to be there.
Two gynecs, 2 consultants.
Agreed. Fine. Given. Okay. Thank you so much.
Good, Bharti. Excellent. Very nice.
Thank you.
So we are so united that surgeons do not have any
So
rule.
no surgeons.
When you are better
That's a
equipped
final
and
decision,
experienced,
yeah.
why to call a person who doesn't
Yes.
have that kind of experience?
Agreed, but call Anu.
No, I'm not
Second
saying that.
Second
I'm not
obstetrician.
saying that.
No. Matlab, since you are here,
Yes, of course.
call,
Yeah.
call, I can call
Anytime.
Jyoti
Anytime.
Gobe, she's next to me. Yeah.
Anytime. Yeah.
Thank you, seniors. We'll move on to the next session because the discussion will be really endless. I request Jyoti to take over. Jyoti, can you please?
Yes. And good evening, all the president, secretary, and all the dignitaries from the all societies who have joined today. Navi Mumbai, Palghar, Raigad, Sindhudurg, Nagri, and Thane. And after the very excellent talk by Dr. Bharti More Madam, now we are moving to the second talk, cervical tear and uterine rupture by Dr. Rajneesh Patel sir. For that, I am inviting as the chairperson. Nilesh, please display the CV. For this, I am inviting as chairperson Dr. Ujjwala Bardapurkar ma'am. She is a postgraduate from VMMC Solapur, holds innumerable posts. She is the director of Yash Nursing Home and Sonography Center and president of Indian Medical Association, Bhiwandi, for the last 4 years. She is the working committee member and treasurer of Thane Obstetric and Gynec Society and executive committee member of Middle Age Committee, FOXY. She is member of COVID Task Force, member of Mortality and Vaccine Adverse Effect Committee, Bhiwandi Corporation, and member of PCPNDT Committee of Bhiwandi Committee, and a member of Maternal Mortality Committee, Bhiwandi Corporation. She has been bestowed upon the President Appreciation Award from the Maharashtra State IMA 3 times. She is a recipient of Mediqueen Excellence Award by Honorable Governor of Maharashtra in the year 2022. Bhagat Singh Ji Koshari. She has received the Appreciation Award from the Maharashtra Governor Shri Bhagat Singh Ji Koshari for her noteworthy contribution to the Pradhan Mantri TB Elimination Program. She was awarded the Leading Gynecologist Award by the Economic Times, Arogya Ratna Award from the KDMCS Seva Purti Kritarth Puraskar from the state IMA. We welcome you, Ujjwala Madam. Our next chairperson today is the Dr. Neena Dhar Madam. She is consultant obstetrician and gynecologist, Seawoods Hospital, Navi Mumbai, and practicing since over 26 years. Our area of interest are high-risk obstetrics. We welcome you, ma'am. Our third chairperson today is Dr. Sandhya Saharan Madam. She is the past president, Thane Obs-Gynae Society, and honorary joint secretary, PCOS Society of India, MCM, PSC, FOXY. Her area of interest are endoscopy, PCOS, infertility, and yoga. She is the consultant obstetrician gynecologist in the Jupiter Hospital, Thane, and LH Hiranandani Hospital, Kaushalya Medical Foundation, Cura IVF and Birthing Hospital, and she got the Young Scientist Award in 1994. She devised nomograms for the labor monitoring, recipient of H. Desa Silver Jubilee Award in 2001, and she received Best Paper in International Congress on Infertility in 2003. She received Bharat Jyoti and Best Citizen of India Awards in 2007. She was the peer reviewer in Jogi since 2014, and Golden Healthcare Achiever Award she got in the Tiara Mrs. India in 2019. Salam to the COVID Warriors Award she got in 2021. She got IMA Olympics 2021 Badminton Gold Winner. We welcome you, Sandhya Madam. I request Ujjwala Madam to introduce our esteemed speaker, Dr. Patel sir, Rajneesh Patel sir. I request Neena Dhar Madam to introduce this topic, and I request Sandhya Saharan Madam to conclude the topic. Ujjwala Madam. Ujjwala ma'am.
Actually, Dr. Ujjwala has sent her regrets. She is busy.
Okay. Neena ma'am, are you there? Neena ma'am?
Hi, good evening, friends. I would introduce Dr. Rajneesh Patel, who is the next speaker of today. He is a past president, Thane Obstetrics and Gynec Society, with a double gold medal in MD from BYL Nair Hospital, 35 years in private practice, associate honorary professor at Rajiv Gandhi Medical College and Chhatrapati Shivaji Maharaj Hospital since more than 25 years, and head of the Unit 3. Recognized basic laparoscopy skills course instructor at the Royal College of Surgeons, UK. Member of Maternal Death Review Committee, Thane Municipal Corporation. Visiting consultant, Jupiter and Kaushalya Hospitals, Thane. peer reviewer for the Journal of Surgical Simulation, JSS, recipient of Thane Gaurav Award. Over to you, sir. I'll just give a brief
Thank
introduction
you.
about the topic. The topic already Dr. Bharti, a part of it, Dr. Bharti has already covered. Now, about the cervical tears, which can be a nightmare at times, because at most of the times we know when the uterine is ruptured, but sometimes we don't know if there's a concealed bleeding and we keep on suturing. I have got stuck so many times and I've called for help. And though till now I have not had any mishap to open it, but we would definitely want to know more about cervical tears and how we can prevent these cervical tears. Over to you, sir.
Thank you for the kind words, Dr. Dhar. First of all, let me thank the managing committee, all the members of the Dr. MC Patel's team, and especially Dr. MC Patel for inviting me to this beautiful webinar. The topic given to me was cervical tear and ruptured uterus. If you want to talk on a topic in obstetrics with so many luminaries around you, you can carry on for a few hours on the same topic. And if you want to gloss over it, you can finish it off in 10 minutes. So I don't know whether I'll be able to finish it in 20 minutes. Instead of starting with the cervical tear, I would like to start with ruptured uterus, which is much more catastrophic than just a cervical tear, with the permission of Dr. MC Patel. Is my screen visible to all of you?
Yes, sir. Sir, please do full screen, sir.
Is it not on full screen?
Sir, actually, you start a slide, actually, then only. I am seeing you are actually, I can see, only your desktop is seen.
Only the desktop is seen. Dr. Bharti More, have you stopped screen sharing?
Sir, we can see your screen, Dr. Rajneesh sir, but you have to select the presentation which you have to display.
Yeah, I have selected the presentation and it is playing on my...
You can stop share and reshare, sir.
Yeah,
it is
that's
not
what
showing the presentation.
Is Dr. Bharti there? She should have stopped sharing in the first place.
Yes, sir. Bharti madam stopped sharing, sir. When I was played the CVs, she stopped.
Your
Now we
screen
can
is
see-
visible nicely and it is full screen also.
Thank you, Dr. Sneha, and all the best for the next 8 days.
Thank you, sir. Thank you.
Yeah. So as I said, I will dwell on rupture uterus first, and then if time permits, we'll go on to cervical tear. Rupture uterus is defined as separation of all the 3 layers of the uterus, including the serosa, or if there is a lateral rupture, it is extending into either the bladder or the broad ligament. So this is what a ruptured uterus is. Unfortunately, or fortunately, we will be seeing a ruptured uterus. Each obstetrician will be seeing a ruptured uterus very rarely in his or her lifetime. So whenever I am referring to rupture, please consider part of me is referring to dehiscence also. Because most of the times what we see in our practice is a dehiscence of the uterus. Now, if you look at the incidence, it's a very uncommon occurrence in an unscarred uterus, only 0.05 or 5 in 10,000 pregnancies. But that jumps to around 0.8 or almost 15 times when we look at patients with previous lower segment cesarean section. And if there is a classical cesarean section or a T-shaped incision on the lower segment, then the incidence jumps almost 100 times to more than 5%. As you can see, last line, scarred dehiscence has an incidence of only 0.6 in all pregnancies. This is just an academic exercise in classifying it, whether it is a spontaneous rupture or a scar rupture or an iatrogenic rupture, and there are many other ways of doing it, like intrapartum and antepartum, complete, incomplete, etc. As I said, it's just an academic exercise. What I would like to now go on to, I wonder why. Yeah, these are the etiological factors, and as you can see, it's a crowded slide. On the left-hand side is a column which says previous pregnancy, and on the right-hand side is a column which says current pregnancy. So many factors are implicated in contributing to a rupture or a scar rupture or a spontaneous rupture. But what I would like you to focus your attention on is that a previous cesarean delivery, a repaired uterine rupture, cornual pregnancy resection, one of the very dangerous things that we do in an ectopic pregnancy for the next pregnancy. Some congenital anomalies of the uterus, unsupervised oxytocin drip, one of the main culprits, a very difficult instrumental delivery. These are some of the common ones that we come across in our usual day-to-day practice. There are many other risk factors. As I said, a dehiscence and a rupture is going to overlap over each other during my talk. So if you see the first 5 lines or 6 lines, they are mainly for dehiscence. Even the next few risk factors that I have listed are for previously scarred uterus and not a spontaneous rupture. What I want you to learn from this slide is that it has been proved beyond doubt that if you are giving a vaginal trial of labor to a patient of previous cesarean section, the interval should be at least 2 years. It has been proved beyond doubt that less than 18 months, the incidence of rupture is almost twice as compared to more than 2 years. Similarly, this was a little bit of a revelation to me that prior preterm cesarean section is an increased risk factor for subsequent rupture. And I was thinking to myself, and I thought probably it is because the lower segment is not well formed. And sometimes we tend to encroach upon the upper segment, and that is why there is a twofold increase in the incidence of rupture when there is a prior preterm cesarean section. Jury is still out on whether we should be doing a single layer closure or a double layer closure. As residents, we were all taught double layer closure. We have now become lazier and gone on to single layer closure. There are 3 or 4 studies which vouch that double layer closure is better. I also came across 2 studies which said that there was no difference. So I leave it to you people. I was wondering whether anybody even thinks about VBAC in previous 2 cesarean sections, but apparently in the NICE guidelines and in the ACOG guidelines, I found that they do try previous to a VBAC in previous 2 cesarean section. And the funny part was whether you have 2 cesarean sections or 3 cesarean sections or 4, it doesn't matter. The difference is only between the first and the second one for some reason. They were also talking about induction of labor and oxytocin augmentation. Personally, my personal view is I will never do an induction of labor or use an oxytocin drip because there is a 3-fold increase in the incidence of rupture. Most of the ruptures occur during labor, and the peak of labor around 4 to 5 centimeters, 90% of them. 18% occur during the second stage, and 8% of them are identified a little later. Have you ever heard of a rupture of a non-pregnant uterus? I have not heard, but I just came across some instances in the literature which said that trauma, infection, or cancer can also cause rupture of the uterus. Now here, this is a very important slide. I would like all of you to really make it very important in your mind to differentiate between dehiscence and rupture, because dehiscence is a much friendlier condition to deal with. It is less life-threatening for the patient as compared to a spontaneous rupture. Be it dehiscence of the scar or even a ruptured scar. Even a ruptured scar will give you more time than a spontaneous rupture in an unscarred uterus. And I was wondering why people use these terms interchangeably. So I went on to the dictionary and I realized that the actual meaning of dehiscence is just that it's a total or partial separation of previously approximated wound edges. So please differentiate between dehiscence and scar rupture, spontaneous rupture. Now, as far as signs and symptoms go, we'll start from the least one, that is dehiscence, and then the most severe one. 50% of the dehiscence patients are asymptomatic. So most of the times it's an operative finding. You open the uterus and say, I can see the head of the child. This patient has been in labor for too long, etc. These are the comments that come out of your mind. So 50% of the dehiscence patients are asymptomatic. If at all there is a scar rupture, or if there is extrusion or of the amniotic fluid into the peritoneal cavity through the scar rupture, and the amniotic bag is also ruptured, you will get abnormal cardiotopographic patterns. Patient might complain of pain between contractions. Now, this is important. Not only does she complain of pain during, but in between contractions also. And previously, when her lower segment hypogastриc area, where the scar was not tender, she suddenly started complaining of scar tenderness. If you are lucky enough to have a sonography machine in the labor room, then you can always diagnose dehiscence by putting the probe onto the dummy and seeing that the scar thickness is less than 1. Severe cases is a real emergency. Most of the Western literature says that any labor room should be equipped with facilities for doing a cesarean section within 20 to 30 minutes. But believe me, if there is a spontaneous unscarred uterus which has ruptured, it will not give you even 20 to 30 minutes. Unfortunately, we will not have enough time to use our technology, and you will have to rely completely on your clinical acumen. The most important symptom that you come across in all the literature that I reviewed before this talk is fetal heart abnormalities. 80% of the patients with spontaneous rupture give fetal heart abnormalities immediately. Most of the times it is bradycardia. Patient may complain of something giving way inside her. The labor ceases suddenly. If you do a per vaginal examination, you find that the presenting part has disappeared. By the time patient goes into hypovolemic shock, and you have to be really fast in getting this patient inside the operation theater and open her up immediately. So as I said, you have to rely completely on your clinical judgment. Most of the advanced diagnostic techniques will not be available to you when you're dealing with this. I have purposely not gone into the details of treatment of ruptured uterus, because then it becomes a big a talk by itself, Resuscitation, meaning 2 large bore needles and cross match, all these things we know. So intensive resuscitation and emergency laparotomy is the treatment for ruptured uterus. Death is not uncommon. Overall mortality is almost 16%, and you lose almost 10% to 50% of the children when there is a spontaneous rupture. So as I said, it's a dire emergency. You have to have your labor room well equipped to deal with this. And although I have learned a little late in life, now I've started doing blood grouping and cross matching for all my labor room patients. I did not used to do it earlier, but now I've started doing it. So treatment is, obviously the treatment choice is hysterectomy. Either you do a total or a subtotal hysterectomy. And as Dr. Parag Patil said, that he is lucky enough to have a cath lab. You can put in while you're opening the abdomen, you can tell your cath lab people to put in internal iliac balloon. I came across 2 papers, Dr. Patil, which said that now they have started doing occlusion of the common iliac more than the internal iliac, and they time their surgery to less than 30 minutes, or they just deflate the balloon after 30 minutes. Very rarely you would like to repair, but as I said, spontaneous rupture is rarer than scar dehiscence or scar rupture, and scar dehiscence or scar rupture usually does not bleed as much as a spontaneous rupture, and you can definitely do a repair of a scar. You can excise the earlier scar and save the uterus if it is just a dehiscence. Another eye-opener for me, that's why we should be taking more and more webinars and lectures, is in our setting in India, and when we were being taught, I never thought of, nobody thinks of an interval eclampsia treatment nowadays, does it? So similarly, nobody thought of an interval treatment for ruptured uterus, but you won't believe this. These are all recently published papers where a ruptured uterus has been conserved to increase the salvageability of the child. So there are cases where they have opened the uterus, they have opened the abdomen, sutured the uterus together, and the pregnancy has been carried on for say 2 or 3 weeks or 4 weeks more, so that the child becomes of salvageable age. So there is some place for interval treatment in even scar dehiscence and scar rupture or spontaneous rupture. So how do we prevent? I wanted to actually focus a little bit more on VBAC. And that is why I'm glossing over the actual treatment of ruptured uterus, because that comes only with experience. You better call some senior person if you're not very happy with your own confidence levels. The most important thing in prevention is not to take the decision to do the first cesarean section very lightly. As we shall see a little later, the driving force behind the unacceptable level of cesarean sections in modern private hospitals today is previous cesarean section. And that is why VBAC becomes more important. Well, the other things are, of course, high index of suspicion, very close monitoring of the mother and the fetus, etc. And we are being nowadays helped with 2 scores, which I can elaborate upon later, the Grobman and the Flem scores, which help you to decide about VBAC. These are some of the recent terminologies. TOLAC is trial of labor after cesarean section. So the bane of increasing cesareans in today's world, these are figures taken from the Ministry of Health and Family Welfare, not my own figure. This is a March 23 article in the Deccan Herald, which says why cesarean sections are increasing in India at such an alarming rate. And I think part of it is this application of CPA to our profession. I mean, all of us agree, right? I would rather do a cesarean section in a primary than face litigation for either a damaged child or a lost child in court of law. So that is partly of it. This is 2021 data all of the states in India. And I was shocked to see some of the percentages. If you can see the red line, 74% in Odisha, 70% in Sikkim, 94% or something like that in Andaman and Nicobar Islands. But anyway, the long and short of it is that the cesarean section rate in India is increasing. And the only way that we can decrease it is by indulging in VBAC. VBAC has been defined as attempting a vaginal delivery in the 37 plus weeks singleton pregnancy presenting with vertex. So everything else is excluded. If it is not a singleton pregnancy presenting with vertex and it is not 37 weeks, it's contraindicated for VBAC. Obviously, the previous history review is very, very important. These are some of the contraindications. Previous uterine rupture, classical scar thickness less than 3 millimeters. One paper said less than 2 millimeters. Can we try VBAC in twins? I'm not sure. Can we try it in previous to LSCS? Personally, I will not. And I'm just reminding you about this slide that I had shown you earlier, whether we should, just to emphasize upon the other contraindications like post-dated pregnancy, maternal age more than 40, obesity, etc. Previous vaginal delivery before or after the cesarean section is the most successful predictor of VBAC. And if you have a patient who has had one cesarean section and one vaginal delivery, please go ahead and try a VBAC on that particular patient. How many minutes I have? 5? Okay. So these are 2 scores which I wanted to share today, which I was very excited to share with all the audience today. This one is the Grobman score. For those who are interested, please take a screenshot. It's an antepartum score. I'll just show you this score live. all you need to do is go to that particular website. This is the website. All you need to do is go to that website and just enter. There are two options available: early pregnancy and delivery admission. So if you take early pregnancy, you just enter the parameters that the VBAC patient has. Say the maternal age is 35, her height is 160, her weight is say 60 kilos. Previous VBAC, just for the sake of it, no. Arrest disorder means if the previous indication for the previous cesarean section was CPD or not, if there was an arrest. So I am writing no and say chronic any hypertension right now. Yes, press on calculate and get your this predicted chance of vaginal birth.
You have not gone to the website.
I have not gone to the website.
No, it is only the slide which we are seeing.
Oh, okay.
It is not open.
Only the QR code is seen.
Okay, only the QR code is seen, is it?
Yes, yes.
For technologically.
Sir, you need to stop the,
you can tap the
sharing
QR code.
screen.
Yeah. If I stop share.
And now you again share your screen where that page is already open.
Okay, now can you see it?
Yes.
Yes.
Okay, great.
Yes.
You just go that QR code I have specially made for all you people. You can just scan the QR code and you'll be taken to this page. And I have entered your maternal age 35. Can you see that?
Yeah.
Thanks, Anna, for pointing out. Weight 60, no previous vaginal history, no CPD in the previous pregnancy, no hypertension. You just press on calculate and you get your predicted chance of vaginal birth after cesarean section is 67.8%. So this is a really helpful tool which will allow you to decide and offer to the patient also. If I add that there was a previous vaginal delivery here, the chance will jump to almost 95%. See?
83.
The chance of vaginal birth after cesarean is 83%. So this is when the patient comes to you in the antepartum period. We have another score by a gentleman called James Flem, which is the next one, is when the patient comes to you in labor. This is the one, it's an intrapartum score. It is exactly the same, except that there are two more parameters added, and that is cervical dilatation and effacement. So these are, I found them to be really helpful, and it would be a real nice data to have in front of you when you're talking with the patient also. Whenever you're trying a VBAC, the discussion has to start in late second trimester and not at the time of EDD. And patient and the obstetrician has to take a joint decision whether they want to do a VBAC or not. Needless to say, you should have a one-to-one care for the patient, a continuous CTG monitoring and very close monitoring of the child and the mother both. Thank you very much. I think I finished 20 minutes of my time. If you want to carry on with cervical lacerations, I will, but I think various kinds of laceration. Only one thing I want to say, in my life, I have had the misfortune of rushing to an obstetrician's help. My neighborhood obstetrician called me and said, Dr. Patel, please come. There's severe PPH and I am starting with a cesarean hysterectomy. So I rushed there. The obstetrician had already opened the abdomen. We quickly went through the hysterectomy, closed the abdomen, and the patient kept on bleeding. And then we did a vaginal exploration and we found a huge cervical bleeder. So before rushing to doing a cesarean hysterectomy, please take the patient to the operation theater. Take her under good light, good assistance, anesthesia, explore the cervix, and please look for these cervical tears. One can also do during repair of the cervical tear, take a prophylactic 3 o'clock and 6 o'clock stitch as high up in the fornix as you can. This will definitely cut off all the blood supply coming down on both sides of the cervix and help clear up your field of vision. I've also done a complete circular interlocking suture, like the surgeons do for a hydrocele, all around the cervical rim when I could not find a single bleeder and the patient was going on oozing blood. So these are some of the things that has happened to me over the years that I've wanted to share with you. Thank you so much for listening so patiently, and thank you again, MC Patel team, for calling me here. Thanks a lot. If there
Patel sir, one question.
Yes.
So would you agree that a Bandel's ring can be a precursor for silent rupture of the uterus, especially in unprimary and a non-tried uterus? A Bandel's constriction ring.
Yeah, Bandel's ring can definitely do that. But coming back to this, I believe that a Bandel's ring most of the times occurs in neglected labor. And if the labor is not neglected, you will never get a Bandel's ring.
True.
And especially if it is a neglected labor with an oxytocin injection. Both the things together.
This is for the obstruction labor. When the labor obstruction is there, obstructed labor and protracted second stage, then the Bandel's ring form. And when you find the Bandel's ring, so if you neglect that, it will definitely rupture. Because the contraction and the retraction forms the Bandel's. So that is why.
So that we should keep in mind. Yeah.
Keep in mind. Yeah. And sometimes you may not find a Bandel rings because of the protracted and prolonged labor and obstructed labor. The bladder becomes high up. So the Bandel's ring behind the bladder. So you will have to palpate and see the ring, Bandel's ring, which is a tougher one in comparison to the other segment of the uterus.
So, yeah, so this is Dr. Sandhya Saharan here. I think Dr. Rajneesh Patel, excellent presentation. I think with all the data which he has painstakingly put up for all of us, especially the calculator, the Grobman's calculator, I think it's very useful. Just a couple of things which I would just like to say about uterine ruptures. Definitely, we see more of them in teaching hospitals rather than what we would see in our private practice. And many a times there have been ruptures in primies, who are very young. So in that case, we definitely would try to salvage the uterus as far as possible. But most of the times they are so bad that, there is a bladder also, which is surgery. So that is one thing about uterine ruptures. And yes, cervical tears. I have seen many buccal handle tears also, especially in patients who had a os tightening done and they've come, with the sudden onset of pain and they've delivered. So these are things which happen to all obstetricians, but it's a very tough topic and very tough to deal with these tears. And I think he's put forth especially the VBAC aspect of it very, very well done and very useful for all the panelists as well as for all the delegates who are attending. Thank you so much, Dr. Rajneesh.
Thank you, Dr. Sandhya, for the kind words. I actually purposely designed my talk more towards how to reduce the incidence of cesarean sections because they are the culprits for having scar dehiscence more often. Spontaneous ruptures are very, very rare, and I don't know. If you take a poll right now, each of us must not have seen more than one or two.
One thing I wanted to point out here, basically the maximum rupture of uterus are intranatal during the labor period. But there are also intrapartum or intrapartum. But there are rupture of uterus has been seen and found in clinical practice. Very rare, that is antenatal during the from 34 weeks to 37. If you have a upper segment classical cesarean section, they without labor pains they can rupture also. So exactly, because sometimes it so happen we don't take the history. The patient is having a cesarean section in a remote area by a surgeon taking a classical section in the upper segment, and those patients are very, very risky, they can rupture, open up antepartum. So that is the important point I want to highlight.
Yeah, so precisely the discharge card is very important as to how the section was done, what incision was taken, what suture material was taken. So these are certain things which we have to keep in mind because, it becomes easier for the next person. Otherwise, you don't know what you're dealing with, especially with the advent of so many myomectomies happening. We never know what happens.
Lap myomectomies.
Yes. Thank you so much for.
It was. Can I add one or two things?
Yes, sir.
Yes.
Dr. Patel, it was really excellent lecture. You have given lot many inputs to us. Two things I just wanted to highlight. Number one is, you said that ultrasound in the labor room, and we can measure the scar thickness. Do you think really it is possible? Because the bladder is empty. And to measure a scar thickness, always the bladder should be full. And it should be, due to stretching, the scar thickness is already flattened. So do you think that it is really possible to measure the scar thickness?
That slide was for diagnosis of scar dehiscence, not the rupture, actual
scar
rupture.
thickness. You said that.
So the scar dehiscence, if you are suspecting scar dehiscence,
Yes, that is
you can
right.
put in a probe and see. That's all. You will
Scar
find a
thickness,
very, very thin layer of tissue above the fetal head. That's it.
But
I
you
don't
cannot
do. I don't
we
do
will not be able to
sonography.
measure the scar thickness. No?
Yeah.
Scar thickness will not. That is one. And another thing you said rightly, that the lateral tears of the cervix means, I don't know whether how many people know, there is a clamp, that is a Piley's clamp.
Yes.
I don't know how many people
Piley's clamp
do have. This Piley's clamp, if you apply and explore it and apply it, you can stop the bleeding before suturing and all that.
Yes.
So that is one thing just I wanted to add. I don't know how many people are having those Piley's clamps because it's not available even in the market. Not all people are having, but it is really a very nice instrument to stop the cervical bleeding, cervical tear bleeding and all that. Thank you, Dr. Rajneesh.
Thank you so much, Professor.
Thank you.
Thank you.
Thank you so much. Thank you, sir.
Sir, MC sir, ayat ka gine.
Yes, sir.
Any comments, sir?
Yeah, I will take it during my lecture.
Okay. Thank you, everybody. Thank you so much.
Yes.
Thank you.
Thank you very much, sir. And Patel sir, very nice talk. And if there is any question and answer, we will take it afterwards.
Okay.
And actually, your talk reminded us all when we are PGs and when all of a sudden the strong labor pain stops and sister says, "Abhi pain nahi hai, patient so rahi hai." That actually triggers. Yeah. This is the classical cesarean section. Now it opened now. So
warning.
Yes, thank you very much, sir, for the elaborated talk, and thank you all the chairpersons and faculties for your inputs. Now I am handing over the session to Dr. Kalpana ma'am.
Thank you so much. Now we will move on to the most awaited topic, legal issues in obstetric injuries, which is none other than by our program director, MC Patel sir, who is an expert in that and ready to help each and every gynecologist before any litigation. So I invite chairpersons, Dr. Girish Savant sir, gynecologist, obstetrician, laparoscopic surgeon, practicing for the past 16 years, director, Bloom Maternity Home, managing committee member, Navi Mumbai Gynec Society, member of WealthCon Doctor Community of Finance and passionate singer. Welcome, sir.
Thank you, madam.
Our next chairperson is Dr. Bala Sahib Bade, who is fertility consultant and also director of Foxy Recognized Advanced Fertility Training Center, director of Postgraduate Institute of Obs-Gyn, Yashoda Hospital, Navi Mumbai, program director of MUHS Fellowship in Reproductive Medicine. Welcome, sir. Our next chairperson is Dr. Jyoti Bobe, madam, president of Navi Mumbai Gynec Society and practicing for almost 31 years with rich experience in Obs-Gyn, consultant at Anuja Nursing Home, Apollo Hospital, and many prestigious hospital. Welcome, ma'am. It is a here, and I request Dr. Girish sir to invite the speaker, and Dr. Bala Sahib sir to give an intro about the topic, and Jyoti Bobi madam to conclude after our program director's talk. Over to you, Chairperson.
Yeah, thank you, Kalpana madam, for the introduction. It's a privilege to be a part of sir's webinar. Sir has been doing it since past 2-3 years, I guess. Thanks all the organizing chairpersons. Thanks all seniors, Kalpana madam, MC Patel sir, Sneha madam, Sina madam. MC Patel sir, introducing him is a privilege. I don't think he needs a formal introduction. And he's going to be speaking on medical legal issues. So it is something like a Sachin Tendulkar being given an opening slot. So since I'm told to introduce him, so many things, I'll just go through them in a short time. Sir is a gynecologist and medical legal counselor. He's the Vice President FOGSI 2018, Organizing Secretary ISUG 2017, Chairperson Ethics and Medical Legal Committee FOGSI 2011-13, Honorary Secretary, State Organization and Gynecologist of Society of Gujarat 20-24, Organizing Chairperson MMCon 2018. Sir holds so many posts. I mean,
yes, it will do, Girish.
Yes, sir. Okay. Thanks a lot for relieving me. Thanks a lot, sir.
Yes. Bala sir.
Over to you, sir.
Yes. Bala sir for opening remark. Bala sir.
Bala Sahib sir.
Has he joined or?
Jyoti Bobi madam.
Yes, Jyoti Bobi madam can also give opening remarks and we can go to the subject.
Yes, thank you very much, sir, for this opportunity. I really thank Dr. Sneha, who is my dear friend, and MC Patel, sir, for giving us this opportunity. OGS is very proud to be associated with this webinar. I request you to start your lectures. Thank you so much.
Before I go to the subject, yes, you mentioned about Dr. Sneha. Sneha is contesting for the post of Vice President FOGSI this year. And she is very hardworking lady, and in this series also she is since long. So we request on behalf of our Happy Learning family to endorse her candidature and support her. And few of our other members are contesting for post for chairperson. Say, for example, Kalpana is going for Infertility Committee. Jyoti Banglawala is for Ethics and Medical Legal Committee. Suman is going for Vaginal Surgery Committee. And two of our guest panelists, Dr. Bharti Rajsekhar from Asan, she is going for NCD Committee. And Dr. Kavita Barnwal from Bhagalpur, she is going for Urogynec Committee. All are working very hard in FOGSI since long. So I appeal to vote for them and support them. And straightway to my topic. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Obstetric injuries, medical legal connotations we are going to discuss for today's webinar. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this, all the president and secretary of respective society, and all the delegates who have joined this webinar. Usually I start any of my talk with this question: is it worth discussing? Yes, and if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. And that is why we have to discuss this topic with our clinical discussion. Let us see, this is figure of American journal. In USA, 78% gynecologists should at least once, 37% gynecologists should on 3 or more occasions, and nearly half of the malpractice claims relates to obstetric problems. And same goes with statistic of professional protection scheme, which is run by Gujarat State Branch IMA. And in that series also, it comes almost up to 18 to 20%. It means every fifth member of that scheme is facing litigation in one way or other, either at notice level or district forum or state level or national level or Supreme Court. So 18 to 20%, we have to consider that serious statistic also. And malpractice suits and allegation of negligence in obstetric cases, especially related to maternal and fetal birth injuries, are rising in India also. And patients with high-risk pregnancy are being viewed as a potential courtroom adversary by our advocate friends. So this is a real scenario in day-to-day practice. Let us see this famous case of baby Ramya. It was forceps delivery, delivered baby of 4.5 kg vaginally, and she ended into brachial palsy. Defense on part of doctor was, it was complicated case. Patient refused for consent of cesarean and baby was getting asphyxiated. So this was the defense on part of a doctor. But inference held by the court was, patient was admitted at 6 a.m. Delivery started at 4 p.m. No investigation or sonography from 6 a.m. to 4 p.m. and no evidence that consent was refused. So here comes a role of negative consent. If at all you feel that cesarean section is very much needed and patient party are not ready to give consent, you have to go with negative consent. Because in court of law, it becomes a good defense in your favor. But many a time, patient or patient party are not ready to give negative consent also. So in this situation, you can have a signature of any co-patient or any visitor of hospital that before us, they were explained everything. Cesarean section was advised, but they refused to go for. So if we have taken this type of negative consent, then it becomes a good defense. In this case, compensation of rupees 1.75 lakhs was awarded in favor of patient. So as far as this particular case is concerned, medical legal comments, case law cannot be adhered to a standard of practice. It is very simple. Law doesn't teach you medicine. How to manage patient, it is as per standard textbook, as per standard practice prevailing in nearby medical college, or standard practice prevailing in peer groups, or standard guidelines given by FOXI, RCOG, ICOG. That way we have to practice. And we have managed, rightly mentioned by Dr. Rajneesh Patel also, one guideline. So if we have managed patient as per standard guideline, it shows our consent to take utmost care as per standard guideline, and it becomes good defense. So case law cannot be adhered to a standard of practice. Medically, it is known that USG is not accurate indicator of fetal weight as perceived by common man and court many times. We know limitations of our sonography findings also. In any case, can it predict disproportion or difficult delivery? So it is our clinical acumen only that we can judge the situation. And in rural area, many times this type of facility may not be available, sonography or so. And this case was poorly represented in court of law. Otherwise, this case was not to be lost. One more case. In this case of Nina Gupta, again it was case of forceps delivery, and ultimately she ended into uterovesical fistula. And defense on part of doctor was it occurred due to process. But this defense was not taken into consideration in court of law, and he was held liable for this uterovesical fistula. So as far as birth injuries are concerned, related to maternal injury, that is obstetric, that is anal sphincter injury, vulval, vaginal, pallidal lacerations, tear or hematoma, paraurethral, urethral or bladder injury, VVF, RVF, cervical trauma, uterine rupture, whether it is repairable or it is to be removed. So these are the areas where one may end up into litigation. As far as fetal part is concerned, fetal asphyxia or birth asphyxia, iphel hematoma, fracture, scalp, long bone, clavicle, urge palsy, injury during breech delivery, sharp cut on fetal body at the time of cesarean section, and perinatal death. So these are some areas we may end up into litigation as far as birth injuries are concerned. And this is very obvious that fetal injury, especially those leading to permanent liability are more likely to end up into litigation. So we should be careful whenever we are dealing with this type of situation. And which are the common allegations as far as this litigation part is concerned? Improper diagnosis of fetal distress leading to a delayed delivery, improper monitoring of process of labor leading to complicated labor, improper interpretation of CTG. Partogram and CTG are good record in our favor whenever we are facing litigation, but many a time there could be allegation on part of prosecution that it was improper interpretation of CTG, improper application of instrument for operative delivery, and improper conduction of labor causing perineal tear and improper repair of that tear. So these are the areas. And as far as role of cesarean section, we are in a tight situation because on one hand, media is crying loud that there are increasing rate of cesarean section. And on other hand, in few of the cases, even court has also mentioned that why you didn't go with cesarean section well in time to avoid this type of situation. So litigation for not doing cesarean section in time is also one more area in this type of situation. So which are the areas as far as litigation part is concerned, where thing goes wrong? Many times whenever we are facing, say for example, complete perineal tear. So on part of prosecution, we have to face certain question, and very important question they will ask, was it preventable? And usually we cannot say because so many complications are preventable. So if it is yes, then one more question he will ask, what did you do to prevent it? So all the measures to prevent obstetric injuries, we have to mention in our record so that we can prove in court of law. Why you couldn't prevent it? In spite of all your care and caution, you may not prevent in few of the cases. Then you should be in a position to justify why you couldn't prevent it. Did you diagnose in time? If at all there was injury, then did you diagnose in time? And very important question, did you manage way in which any prudent doctor would have managed? So you would have managed the situation way in which any prudent gynecologist would have managed in the same given situation. So if we can prove in court of law or answer all those questions, then we are in a safe position as far as litigation part is concerned. And it is always obvious, prevention is always better, but prevention may not be always possible because we take utmost care of any of our patients in obstetric like this, but accident may happen at any time and we may end up into litigation. So during cesarean section, proper care not to injure presenting part of baby is very vital point as far as this injury to the baby is concerned. And few of our friends have a habit, use of 2 Ellis forceps on lower segment and cutting in between and splitting remaining fibers with an artery forceps to prevent or to avoid injury to fetal part. Delayed in diagnosis and misdiagnosis. If at all there is injury, but if we have delayed in diagnosis or if we have missed that injury, then also we have to face litigation. And the same question we will have to be ready to face. Was it preventable? Yes. Why did it? Why you couldn't prevent it? Why did you? What did you do to prevent it? Did you diagnose in time? Did you manage way in which any prudent doctor would have managed? So all those questions you have to face in this type of situation. One more area, damage to vital organs. Say for example, if you are dealing with a previous 2 LSCS and this time you are dealing with a cesarean, it is all likely that you may end up into bladder injury due to dense adhesion. So damage to vital organs is one more area in our obstetric practice. And again, all those questions you will have to face. So every complication related to obstetric injury is a potential threat as far as litigation is concerned. So look like avoiding medical legal problem in practice is a difficult balancing act. No, not at all. Then what to do and how to prevent? So practice foreseeability, that is anticipation, good communication and proper consent and proper documentation, and you will simply sail through. So as far as foreseeability or anticipation is concerned, court expect from us to anticipate certain complications. Just I mentioned about dense adhesion. So we should anticipate that it may end up into injury to bladder or any other organ also in few of the situation. So if we have anticipated and if we are readily available to deal with the situation accordingly, then it becomes a good defense. But in this type of situation, proper counseling is very much important. When you are dealing with the case of previous 2 LSCS or 3 LSCS or any other complicated delivery or high risk pregnancy, then proper counseling should be a very much important part of your counseling, because they should be mentally prepared to face this type of complication or even morbidity in few of the cases. Because as far as our counseling part is concerned, usually we start like this: what is the complaint? But there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So there are so many questions on part of patient. So at the time of counseling, we are under obligation to explain everything related to alternative modalities of treatment. We can offer all the treatment plan and we can select most appropriate treatment plan in favor of patient. But we should discuss everything to the patient with all its positive and negative outcomes. Possibility of morbidity should also be counseled. Expense, probable expense should also be told. Mortality in very few of the cases, of course, but if we are dealing with this type of cases, we should mentally prepare all the relative that we are trying our level best, but anything may happen. Prognosis also we have to tell. All the probable complication we have to discuss at the time of counseling. Possibility of blood transfusion also we have to mention, and all the risk involved in the treatment plan we should explain. And naturally, need of NICU and outcome of baby should also be discussed at the time of counseling. But whatever we counsel, it should be in a very simple language, no much medical jargon, and no rosy picture about result, no tall claim about result. Because in eye of law, when you claim to be master, you are supposed to be master. And in our obstetric practice, we cannot give any kind of rosy picture or tall claim, because in our practice, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture. Post-delivery counseling is very important. And whenever you have faced any complication, say for example, bladder injury, you have already sutured, but post-delivery or post-cesarean, this counseling is very much important, because naturally you are going to keep catheter for longer time. And if you have not counseled them properly, they will not take proper care of catheter also, and it may end up into one more complication in future. So post-delivery counseling about injuries, any kind of injury, not only bladder, even perineal tear, complete perineal tear, paraurethral tear, cervical tear, or uterine rupture, you have to counsel for that also, that what has happened and what you did as far as treatment part is concerned. About repair, you have to mention everything in detail to the relative. Future treatment plan, if at all it may end up into bladder injury, you have suture. But as a word of caution, you may tell that in few of the cases, possibility cannot be denied about VVF. So if at all it happens, then what will be the future treatment plan? We may explain that also at the time of post-delivery counseling. So proper communication and proper documentation is very much required. And this is very important case which happened in National Commission, C. Jaipal Reddy versus Padmini Veluri. National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is an important document of your communication, of your counseling. So whatever you have counseled, you have to mention in consent paper. So each and every point you have to mention in consent. And when patient signs that document, it becomes a documentation of your communication. So whatever you have communicated is documented by patient. And when you offer all those documents in court of law, it becomes a communication of your documentation. And this was discussed prior also. Well-informed consent is very important defense, we know. But is it expected to take written consent for labor also? Because one point was discussed in this. So in India, this is not routine practice. Does it mean that process of parturition is a physiological and it is implied that patient is aware of all risk involved? And if not taken, how to defend in case of complete perineal tear? So as far as consent or counseling for normal labor is concerned, it is very much important. And I would like to mention, it is available on FOXI website. You have to simply visit FOXI Uniform Consent. We three medical legal experts, Dr. Dilip Phalke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. And in those consent for normal labor is also there. We have mentioned everything as far as normal labor, about all these possible complications. Say, for example, complete perineal tear or so. We have mentioned everything. We have mentioned possibility of instrumental delivery. We have mentioned possibility of cesarean section also. So once patient goes through that consent and patient signs the document, it shows that you have counseled patient well before entering into labor. But where this consent should be taken, because many a time there could be argument on part of prosecution that when consent was taken, patient was in agony of labor pain. So consent is not valid consent. So when this consent should be taken? Consent should be taken when patient is with sound mind. So if it is your book patient, you can give this booklet to the patient during your antenatal visit also. Patient can go through it, and patient whenever comes next time, get it signed by patient herself. Is parturient who is in pain and agony capable of giving consent? Could be argument on part of prosecution. And now I am happy to announce that now all those consent which are in English on FOXI website, now it is available in Marathi also. It is available in Kannada also. So we can use that consent in Marathi. And if anybody is interested to have a soft copy of that Marathi consent, it is available with me also. Anybody can contact me. I will provide this. At the time of registration or booking, we can counsel patient for normal labor also. Reinforce at the time of admission if it is your book patient. If it is unbook of emergency patient, then at the time of admission, we may have consent for this also. In government hospital, many a time, this is argument on part of doctor facing litigation. Due to heavy workload, we cannot counsel patient well because we have no time. But this kind of argument court doesn't take into consideration. So we are under obligation to counsel patient very properly. This was one more question asked at the time of famous case of Samira Kohli versus Prabha Manchanda. Does Supreme Court expect us to talk about all possible complications? So in this case, Supreme Court has very specifically mentioned to anticipate certain complications or requirements depending upon the condition of the patient, and no need to explain remote or theoretical risk involved, which may frighten or confuse the patient and result in refusal of consent for necessary treatment. So it was very clear on part of Supreme Court in that very famous case. Need to explain risk of refusal of treatment also. If patient refuses for consent, then we have to explain that also. But at the same time, Supreme Court has mentioned no need to explain remote or theoretical risk of refusal of treatment, which may pursue the patient to undergo a fanciful or unnecessary treatment. So at the time of counseling, balance should be achieved. Which kind of complication we have to mention, and remote complication we have not to mention. Is it expected to take a written consent for refusal? Yes, always yes, because negative consent is equally important. I just mentioned prior also. So it is available on FOXI website. Just I mentioned about uniform consent. We have prepared consent in two parts. Part one is information, and information we have divided in 8 subheadings, and it is as per guideline given by Supreme Court in that famous case of Samira Kohli versus Prabha Manchanda. And at the time of preparing this consent, we had a collaboration with Maharashtra Law University and 2 retired High Court judges, 1 sitting High Court judge, 1 sitting judge just retired from National Commission. They were in our collaboration, and at the time of preparing this consent for one word or for one line, we had a ample discussion for hours together with all those legends in legal system. And then after we have come up with this consent. So as far as this subheading of information part is concerned, name of procedure, say for cesarean section. Meaning, what is the meaning of cesarean section? We have mentioned in a very simple language, layman's language, to cut open abdomen, to cut open uterus, and to deliver baby. Like that. Purpose or indication, we have mentioned all indication, and we have keep blank at the end of this indication. So if any new indication is there, you can mention that indication also. Description of procedure, how cesarean section is done, what is elective cesarean section, what is emergency cesarean section, we have mentioned that also. Benefit of procedure, what is the benefit of cesarean section? Alternative, if patient is not ready to go for cesarean section, which are the alternative? Consequences of refusal of procedure. If patient is not willing to give consent, then which are the consequences of refusal? We have mentioned in that consent form also. And outline of substantial risk of anesthesia, possibility of excessive bleeding and blood accumulation, possibility of infection, injury to surrounding structure. Every individual has a different way to cope up. So possibility of adhesion in future, possibility of hernia formation in future, we have mentioned that also. Very rare condition, that is allergic reaction to the drug, and outcome of baby neonatal morbidity, we have mentioned that also in that consent. And part 2 is undertaking. So whatever we have explained in part 1, patient will go in undertaking in part 2. But very important part we have mentioned, this is part 3. I understand that during course of surgery, doctor may find other unanticipated, unhealthy condition that may need specific action, procedure, surgery, or anesthesia. If doctor feels that it will be beneficial to treat such condition while performing proposed surgery, and if I am not in a mental or physical capacity to give consent, doctor may take necessary decision after discussing with Mr. or Mrs. So-and-so who is waiting outside labor room or operation theater. I authorize above mentioned person to give proxy consent on my behalf. So in this situation, if you have to go beyond the scope of consent given by patient, and if patient has given authority to some person, we can discuss with those person and we can proceed accordingly as far as our treatment plan is concerned. We have mentioned this also. In order to save life, it may even be necessary to do additional surgery or procedure and prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. If patient has given consent like this, then no need to discuss with relative also, and straightway you can proceed accordingly. And at the end of consent, we have to go with signature or thumb impression, whatever the case may be. And if it is thumb impression, then thumb impression should be well attested by a person who knows the patient. But in this situation, that fellow should be major and should be with mentally sound mind. 2 witnesses, one in favor of hospital and in one favor of relative. And consent, signature of doctor is also very much needed in consent form, because you will be surprised why signature of doctor is needed in consent form. Because as soon as you accept any patient to treat, it becomes a contract between patient and yourself. It is implied contract in eye of law. You are offering your expert services and patient pays for that, or patient promises to pay for that. So it is a contract. And under Indian Contract Act, unless all the party involved in the contract signs the document, document is not complete. So to make this consent complete, signature of doctor is also very much required. But records are always at your rescue. So keep them up to date. What was done, nothing was neglected. Given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. This is very important. Discharge card. Give proper instruction to the patient at the time of discharge about diet to be taken, about medicine to be taken, about exercise, about follow-up, and references. If you have given any reference to any doctor to the patient, it is also to be mentioned in discharge card. Because in this very famous case which happened in state of Tamil Nadu, in this, it was premature delivery. Baby was admitted in NICU. In due course, baby was discharged. But at the time of discharge, parents were not counseled and not advised to go for ophthalmic opinion to rule out retinopathy due to prematurity. And ultimately, this baby went blind. Case was filed. And in this case, judgment came with compensation of 1.8 crore in favor of baby and relative. And out of those, 1.73 crore was to be paid by Tamil Nadu government because it happened in government hospital. And rest of the amount was to be paid by neonatology. In this case, gynecologists were not made party. They were happy with the treatment part as far as gynecologist role is concerned. Doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn. So it is very obvious that good record is good defense, poor record is poor defense, and no record is no defense. And it is my experience during my medical legal practice, we doctors are very poor as far as record keeping is concerned. And in some of the lecture, somebody introduced me as a Bhishma Pitamaha as far as medical legal part is concerned. But I say that Bhishma Pitamaha had to sleep on Ban Saiya. And if our colleague, when comes to me and when I am defending them, and when they are with poor record, my situation is like Bhishma Pitamaha or Ban Saiya. So please be aware that your record should be very updated. Give follow-up treatment to the patient who has given you a notice. This is also very much important because many times when patient serve with a notice and you are not giving follow-up treatment. So if as usual, this is not exceeded, then case may be filed. But on other hand, if answered properly, may prevent further litigation. This gentleman has so many staircases, but he doesn't know how to use them. There are so many case laws in our favor. There are so many guidelines illegally in our favor. But if we do not know, it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. There is always a way. So to conclude, minimizing birth injury claims, labor wall protocols, adequate supervision and monitoring during antenatal period, during perinatal period, and in few of the cases in postnatal care also, proper communication, counseling and consent, proper documentation and record keeping, multi-speciality approach. Whenever you are in need, do not hesitate to have a phone call to your professional colleague to be at your help, to be at your assistance. It shows your consent to take utmost care of your patient. In-time reference is very much required. Indemnity coverage is very much required in era of this CPA. An audit of your own case, not to end up into same kind of problem in future, because in spite of all these professional and occupational hazard, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient. Strictly follow protocols as far as treatment plan is concerned. Pray your Almighty God before going to sleep and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful and in any given situation. So please do not hesitate to have a phone call to medical legal counselor in any given situation, because we are always there to help you, to assist you. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. With regards, thank you, salute to all the societies who have joined this webinar. Thank you very much. Please do not assume. Please ask if any query, any questions, if chairpersons and time permits. Thank you very much. Thank you.
Thank you so much for elaborate lecture. It was really very nice, and basically, thank you for highlighting importance of informed consent as well as very good communication. So role of communication is really very important. Thank you so much.
Thank you. Thank you.
Thank you.
Thank you, Jyoti ma'am, for your.
Thank you very much, Kalpana ma'am. Thank you.
Any other remarks from chairpersons and seniors?
Any senior can have also comment, no issue.
Sir, can I,
Yes,
you
yes.
said
Yes.
something about negative consent.
Yes.
And you can take the negative consent. If the patient is refusing, you said you can take it from a neighboring patient or some other relatives. Sometimes it becomes very difficult to get somebody else to sign. And is it possible for you to take a staff's signature?
No,
Or the staff doesn't count?
You can take, but it won't be considered is a valid part as per court party, because your staff becomes your party.
Yeah, that's why I asked.
Many times co-patient or any other visitor of hospital, if you may convince them, they are ready. But at the same time, all the details of that person who have signed, it should be with you, because at the time of facing litigation, if there is no information about that very person who had signed as a co-patient or visitor, then it will be difficult for you to defend in court of law. Hello.
Okay. And the FOXI consent that you are talking about, sir,
yes.
Will it fall into the category of a blanket consent? Because
No. It is not blanket consent, because it is procedure specific and operation specific.
If you write the name,
I just discussed performa, but say for example, consent for cesarean section is different with consent of hysterectomy, because part 1 is information, and in that information, in each consent, it is different. Of course, part 2 is the same, because undertaking is the same. Because whatever we have explained in part 1, patient is going to go for undertaking, but part 1 is different in each and every consent. We have prepared consent for transferring patient to higher center in difficult situation, consent for cesarean section, hysterectomy. We have prepared 3 different consent for hysterectomy: vaginal, abdominal, and endoscopy. Then medical termination of pregnancy, medical method, surgical method, os tightening. So every part as far as legal part is concerned, we have taken into consideration.
Thank you, sir.
Because we took almost 1 year to prepare all those 30 consent, because we were very much aware, because whenever we are going to put on FOXI website, it should be authentic one as far as legal part is concerned. And still we are open to have any comments, any suggestion that this can be changed in this consent. And we are always open, all these 3 medical legal counselor, Dr. Dilip Malke, Dr. Nikhil Datar, and myself. So always invite your comments and suggestions also.
Yes, sir. As far as I know, I think proxy consent is not being honored in the Western countries. We are lucky that we can still take proxy consent. One of my classmates who was a surgeon rang me up about 25 years back and said, "Rajneesh, तेरे को मालूम है क्या?" बोला, "क्या हुआ?" मैं appendix कर रहा था, छोटा ovarian cyst देखा बाजू में, निकालने वाला था, तो मेरे assistant ने बोला, "मत निकालो, patient का consent नहीं आएगा तब तक."
Yes.
So in the Western world, they close the patient. And take another consent when she comes out of anesthesia and then get to the pathology.
In India also, there are so many judgments. Without consent, you have extended the scope of consent given. Say, for example, simple. You are dealing with a case of infertility for diagnostic laparoscopy. And if you see a big ovaries and you consider that it is PCOD, let us have a ovarian drilling. And if you have not taken consent for ovarian drilling, you cannot do. In one of the cases, ovarian drilling was done. And same way in one of the cases, consent was given for vaginal hysterectomy. And after anesthesia, it was a consent given for abdominal hysterectomy. And after anesthesia, surgeon went with vaginal hysterectomy. and it ended into some complication. Ultimately, laparotomy was done because during ovarian stump, there was profuse bleeding, and ultimately it was injury to major vessels of kidney. It was pelvic kidney,
Oh
and
my God.
ultimately laparotomy was done, and that kidney was to be removed. Of course, there were 2 kidneys, so patient was saved that way. But litigation was done, and in this case, inference held by the court was that bleeding is known complication, but changing route from abdominal to vaginal is not accepted once you have not taken consent for that very route. So we should be very specific at the time of counseling and taking consent.
Sir, Patel
Yes.
sir,
Yes.
one of my doubt is that
Yes.
we are taking so many consent and so many how the procedure is done, but where the complication is mentioned in the textbook and in the literature, why the court of law is not honoring that? Because the complication is written that some people or some experienced people has landed up with this complication. So this complication should be accepted if somebody has done it. If after taking consent, why they are going against us?
Sir, with due regard, I will correct you little. In each and every case, court doesn't take in cognizance of textbook. It is not like this. There are so many judgments. We quote those judgments also. I would like to mention in one of the case, it was case of amniotic fluid embolism, and it happened with one of our Foxian friend in Ghaziabad. In lower court, she lost. In higher court, that is in high court, she lost, and appeal was preferred in Supreme Court. And in Supreme Court, 2 of medical legal counselor from Foxy only had been at the assistance of gynecologist from Ghaziabad, and standard textbook Williams references we put, and we could prove from Williams textbook what is amniotic fluid embolism, and we could convince Supreme Court that it is unanticipated, unexpected. It cannot be predicted in which patient it will occur, and whatever efforts taken by gynecologists was as per standard textbook by Williams and Shaw. The 2 textbook references we put, and in that very case, judgment was in favor of gynecology. So it is not likely that court doesn't take into cognizance. But how you put your case in your favor with all the textbook references and all the good cases decided in Supreme Court in past. So for that, I insist good medical legal counselor should be with you at the time of facing litigation.
Yes. Okay. Thank you.
Dr. Patel sir,
Yes, sir. Patel sir.
it was really an eye-opener for everybody, no doubt. You are master in that, no doubt.
Thank you, sir.
And we still learn lot many things. See, whatever we can conclude from your talk are 3 C's.
Yes.
Most important is counseling. The major part, counseling of the patient and the relatives.
Yes.
First. Second, consents, informed consents, proper consents of each and every procedure. Yes. And third C is correct mention in the papers.
Yes.
आपने क्या किया operative is not important. आपने क्या लिखा paper में?
Yes.
That is seen by the court of law.
Yes.
These 3 C's are very important as far as means the litigations are concerned. So really it was very nice and to hear you again and again and again. I hear you lot. But every time we learn something new.
Something new, yes.
Thank you very much, sir.
And Patil sir, after 3 C's, 1 R is very, very important.
Sure,
retirement. After every such conference, I genuinely feel today is my last day of my practice.
No.
So
why you should retire? You should work till you die. Why you want to retire? No retirement. Doctors have no retirement.
Sailendra, I forgot to mention, usually I end my talk. We are not here to make you fearful. We are here to make you fearless.
True.
How to be vigilant enough in our practice. If you are little vigilant, then you are out of problem.
True, sir. True.
Yes.
You are Bhishma as well as you are.
Pleasure. True.
Yeah, you are not only Bhishma, You are a lighthouse for us.
Thank you, sir.
Always a pleasure listening to you, sir.
Thank you, sir.
Yes, sir. Shailu, just remember that medical legal expert carrying the deer and running.
Yeah.
You won't feel like retiring.
Yes.
No, let Supriya start a presentation. We have a very famous slide coming up.
Shailendra, you don't have to run away. You have to face. That's all.
Face, yes. True,
And
Don't run away.
we are having conference on 4th, 5th, and 6th of August only, just 2 days back. And we are going to have 3 days conference. 1 day is workshop, 8 workshop. It is absolutely obstetric and gynec. But 2 days, 1 parallel hall as far as medical legal part is concerned. 2 days and 1 parallel hall OBGYN. So if at all any query, any doubts, you please come to Ahmedabad on 4th, 5th, and 6th August. And
Sir, from tomorrow only, no, sir?
Tomorrow.
yes, tomorrow. But tomorrow only.
And Ahmedabad is a lovely city in rains.
Yes. Tomorrow workshops and day after conference.
Bit late to know. Koi baat nahi. Next time. So, thank you very much. It was.
Thank you, Chairperson. Actually, sir, we are really enjoying your hard work, not only your Foxy concerns, but also your Happy Learning platform.
Thank you. Thank you.
Thank you so much. Now I request Jyoti.
Yes. Yes. Mr. Nilesh, please play the CVs. Nilesh ji. So, Nilesh ji, yes. So now we are moving to the panel discussion, the labor room emergencies. And for that, our moderators today are Dr. Supriya Arwari and Dr. Deepika Kala. She is the co-moderator. And as you know, Supriya Arwari Madam is the secretary of Thane Obstetric and Gynec Society. And she is practicing at Prim Hospital, Bhiwandi for past 20 years. And she is the National Coordinator, Foxy Adolescent Health Committee and Chairperson of Association of Maharashtra Obstetric and Gynecological Society, AMOX Welfare and Cultural Committee for 2022 to 24. We welcome you, Supriya Madam. Our co-moderator today is Dr. Deepa Kala Madam. She is having the vast experience of 23 years and she did her MBBS from the Topiwala National Medical College in 1995 and MD in 2000 from the Grant Medical College and MS from same college in the Physiotherapy and Management Sciences from Mumbai in 2004. She is MA Yoga Shastra from Padma Yoga Sadhana College, Terna Public Charitable Trust. She is the professor and HOD in the Department of Obs-Gynae in Terna Medical College at present and with the teaching experience of more than 20 years. We welcome you, Deepa ma'am. Today, our esteemed expert comments from Dr. Sneha Bhuyar Madam. She is the ex-chairperson Breast Committee Foxy and she is the GC member of ICOG Governing Council and Suffolk Working Committee member for the Breastfeeding Committee and AMOX Chair for Medical Disorder Committee in 2022 to 24. And she is the founder president of Vidarbh ISOPAM and she got the International MS Signature Award in 2020, Asia GCC Award in 2021, Dr. S.N. Malhotra Individual National Award, Dr. Durusha Distinguished Community Award, Dr. Anandibai Joshi State Award, all the awards she got, Lokmat Healthcare Excellence Award. She is having the vast experience of 20 years and having she has given more than 300, now it must be more than 500 actually. She has given more than 500 talks and publication. We welcome you, Sneha Madam. Our next expert is Dr. Rekha Rajendra Kumar Madam. She is the medical director of Miracle IVF Hospital and Chalna Hospital, Bengaluru, and practicing gynecologist there for the past 31 years. She is the president-elect of Bangalore Obs-Gynae Society for the year 2023 to 24. She is the South Zone Coordinator of Foxy Infertility Committee and Chairperson of Infertility and ART Committee, Kasoga, in 2020 to 22. She got 15 awards and 5 felicitations, including 1 international and 3 state awards. She is ex-PG teacher of MS Ramaiah Medical College and Bangalore Baptist Hospital. She is having 15 original articles, 1 case report, 1 poster presentation in ISHRE conference in 2021. She has given more than 100 radio and television talks, 40 newspaper articles, all on the women health. She has been the speaker, chairperson, moderator, panelist in more than 600 state, national, and international conferences. We welcome you, Rekha ma'am. Today, our panelists are Dr. Bharti Rajshekar. She is the president-elect of Kasoga.
Thank you.
Welcome, Bharti. Welcome, madam. And she is the Indian Red Cross Hassan Director, IMA Karnataka State. She is the past Vice President, and she has just given charge of the Honorary Secretary General of Kasoga. She is the immediate past Secretary of the Kasoga. We welcome you, Bharti, madam. Our next panelist is Dr. Jay Narayan Senapati, sir. He is the professor and head of the department in Obs-Gynae in Rajiv Gandhi Medical College, Chhatrapati Shivaji Maharaj Hospital, Kalwa, Thane. He is a laparoscopic surgeon and consultant in Chhatrapati Shivaji Maharaja Hospital, Thane. He did his MD from Grant Medical College and JJ Group of Hospital. He is UG and PG examiner of Mumbai University and MUHS Nasik. He did He is the DGO FCPS examiner for CPS Mumbai. He is committee member of Maternal Death Review TMC. Member of Negligence Committee Thane District, member of MDR Committee Thane, Raigad and Palghar District, is a member of CDR Committee Thane, President of Thane Obstetric and Gynecologist Society, current year 2023-24. He is having many publications in national and international journal. We welcome Ms. Jay Narayan Senapati, sir. Our next panelist today is Dr. Nageshwari Nanda madam. She is gold medalist in MD from the Mysore Medical College and MBBS from the JNMC Belgaum in 1995. She is the managing committee member talk since 2019 and chairperson of Best Committee, Thane Obs-Gynae Society, practicing since 2001. She is practicing in the Padma Shri Maternity and Nursing Home, Wagla Estate, Thane West. She is the honorary consultant at Jupiter Hospital, Kaushalya Medical Foundation and Fortis Hospital. She is life member of Foxy from the Thane Obstetric Gynae Society. Her area of interest are high-risk obstetric and laparoscopy. We welcome you, madam. Our next panelist today is Dr. Swarupa Iyer, madam. She is MD DGO LLB. She is a consultant obstetrician, gynecologist and fertility specialist and medical legal advisor. She is secretary of Thane Obstetric and Gynae Society last year in the year 2022-23 and member of EMLC Foxy. She is peer reviewer for Journal of Obs-Gynae of India and part of legal team of Apex Insurance. She is practicing since last 26 years at Bapat Nursing Home. She Curie Hospital, Jupiter Hospital, honorary laparoscopic surgeon at the Kutum Niyojan Kalyan Kendra. We welcome Swarupa madam. Our next panelist is Dr. Shailendra Jadhav, sir. He is MD DGO PG DMLS and Chief OCCU and Curie Group of Hospital. He is working in the Curie Group of Hospital. He is Clinical Secretary of Thane Obs-Gynae Society, Chief Coordinator of Flying Squad Thane Obstetric and Gynae Society, graduated from KEM Hospital and Wadia Hospital and PG DMLS done from the Symbiosis Pune. He is practicing since last 25 years and he is having many extracurricular activity in the dramatics and sports. We welcome you, sir. Our next panelist, Dr. Madhumita Dev, madam. She is practicing obstetrician and gynecologist since 1994 with the vast experience of 29 years in day-to-day practice doing obstetric gynecology, bad obstetric history, infertility, OPD, performing routine surgeries, open as well as the laparoscopic and deliveries IUIs. Her expertise in the infertility, patient with the high-risk pregnancy with the bad obstetric history and aesthetic gynecology. She did her MBBS from the Assam Medical College, Dibrugarh and MD from the IGMC, Nagpur. And at present, she is attached. She is having her own hospital, Dev Hospital and Maternity Care Center in the Nerul, Navi Mumbai and consultant at Apollo Hospital, Navi Mumbai. We welcome you, Madhumita madam. Our next panelist is Dr. Mrs. Kranti A. Fadnis madam. She is MBBS DGO DNB FCPS DFP Mumbai, CCGDM CCCMD FMAS. She is the practicing psychological counselor. She presented many papers and won Duru Shah Best Paper Award at the MOX and West Zone U of Foxy. She is having the best paper and poster paper awards for 3 consecutive years in the MOX. Has few publication in Index General. Her area of special interest is high risk obstetrics and gynec onco. She has been a Manyata trainer, assessor and mentor through MOX CSE since last 3 years. We welcome you, Kranti madam. Our next panelist is Dr. Santosh Bhimrao Jaibhai sir. He did his MBBS from BJ Medical College, Pune. Post-graduation, he did from St. GS Medical College and KM Hospital, Mumbai. He is the practicing obstetrician gynecologist and freelancing gynec endoscopist and gynec laparoscopic surgeon in Navi Mumbai and Raigad. He is joint director of Om Sai Multi-Speciality Hospital and Advanced Gynec Laparoscopy Hysteroscopy Surgery Center, Kamothe, Navi Mumbai. He is vice president of Navi Mumbai Obstetric and Gynecological Society, and he is the West Zone Coordinator, Ethics and Medical Legal Committee, FOXY. He is an avid marathon runner and passionate finance teacher to MBBS doctors across Pan India. We welcome you, Santosh sir. Our next panelist is Dr. Kavita Baranwal, madam. She is the senior consultant and laparoscopic surgeon in Samarpan Hospital, Munge, honorary teacher at Lord Buddha Koshi Medical College and Hospital, and recipient of Padma Bhushan Kamla Bai Hospice Award, member of YTP Committee FOXY in 2021 to 23, associate member of RCOG, presented paper in RCOG in 2023 and received Young Talent Promotion Champion Award twice. She is the organizing secretary of 9th AOGS BG in the 2022. We welcome you, Kavita madam. Our next panelist today is. So these are the panelists today, and I am handing over mic to Supriya Arwari madam. Supriya madam, you can share your screen, and I hope the very fruitful discussion for this panel, and the allotted time for panel is 45 minutes to 1 hour. And if the expert comments, Sneha madam, I welcome Sneha madam because she's so busy and hopping between the webinars, and we missed her words of.
I'm sorry. I just not to waste any time. Please let's thank you so much, Jyoti.
Yes, and we wish you all the best, Sneha madam, and. Supriya, mic is all over to you.
Just give me a minute.
Yes. Dr. Kranti, unmute yourself. Kranti ma'am. Kranti ma'am, Swarupa ma'am.
Yes. Yeah, we are there.
Are my slides visible?
Yes.
Very much.
So I welcome all of you here for this very important discussion on labor room emergencies. At the outset, I would like to thank Dr. MC Patel sir, all the organizers that are here today, Jyoti, Kranti, and special thanks to Sneha madam for lending her beautiful slides to me, madam. Really very well done. So without much ado, we will proceed with this presentation. Dr. Deepa, who is my co-moderator, madam, we can take alternate cases. So I begin with the first case here. The second stage of labor is something that we all know. It's a very, very important stage in the process of labor. And only in movies, it is shown very dramatically that in 1 or 2 pushes, the baby is out and everybody is clapping and happy, and probably somebody in the background is fainting or congratulating. What actually, and childbirth as such. All is well. Yes, absolutely, all is well. And childbirth as such is a very important part of the woman's life, and it should be a happy experience for her, not something that will emotionally or physically scar her for the rest of her life. It is an intensive emotional and physical changes are taking place, and ultimately aim of us as obstetrician is to have a healthy mother, a healthy baby, and emotionally fulfilling experience for all concerned, including, I think, the obstetrician. So we will go to the first case. Now, this is a Gravida 2 Para 1 A0 with 36 weeks of pregnancy, came with previous normal delivery, strong labor pains, vitals normal, fetal heart rate is good, 140 per minute, cervix fully dilated and effaced, but she is come with a breech presentation. Now station here is +1, pelvis is adequate. How will you manage? Swarupa, are you there? Dr. Swarupa here?
Yeah.
So would you like to start, Swarupa?
Yeah, okay. So I think we had a lot of discussion on complications of normal delivery, and you're throwing straight away breech to me. So thing is, I always used to get amazed by delivering a breech, and in my residency days, breech was given as a cesarean section for a first poster. I don't know what is the logic. I feel breech is equally complicated as far as delivering through cesarean section is also concerned. But this particular patient has, I think, almost come fully dilated, station is +1. And the best thing about her is she has a previous normal delivery. So the passage and the passenger is well tested here. Only thing is this time it is breech. So I feel obviously we can give her a trial. And in my personal experience, I feel breech delivery is a little slow to progress. So after ascertaining that fetal heart is good, we can do an admission test, record that her fetal heart monitoring is good, there are no decelerations. We can augment it with oxytocin, speedify delivery. And I hope it is a complete breech because we don't know the previous report. But then complete breech with +1 station, I think it should be easier to deliver vaginally. Of course, we can keep all the necessary things required for intervention, if at all needed, like cesarean section, we can keep ready. And then I think we can proceed with the vaginal breech delivery.
Senapati sir, would you like to add something here?
The most important thing in the breech delivery, when a breech comes, what for we are worried about? We are really worried about the delivery of the head. Because there is no molding occurs when it is in a cephalic presentation. Because of the molding, the diameters of the fetal head reduces and the passenger becomes easier to go through the passage. That is the simple. But here, there is no time for molding. The head comes immediately. So every obstetrician is worried about how to deliver head, whether head will be delivered, whether head will be in a flexion position, whether head is in extension position. So a lot of questions remains in the mind. That is a very, very important thing. The second thing, what is the weight of the baby? What is the weight of the baby? Even if she has delivered once, if the weight is, there is a Dhatu-Chini-Andrus score is there that gives around 5 parameters, and one is also the weight. If it is beyond 3.6 kg, we never give a trial to the patient. If there is a preterm labor, preterm delivery, we never give a trial. So there are so many things, not only the one particular point where we can decide if this patient can be delivered vaginally or can be delivered by cesarean section. So what Swarupa told, that you will have to keep ready any time for a cesarean section, but not that vaginal delivery cannot be done. And it is very, very interesting because as all of us know the different types of vaginal delivery, that is a spontaneous breech delivery, then assisted breech delivery, and there is a extraction, breech extraction. So most probably the breech extraction we do in a cesarean section or a dead baby or for a second of twins. So there are certain things we do in the breech extraction, but everybody should know, or when you are doing assisted breech delivery, you should know what are the different stages, the leg extraction leg, then the hand, then the shoulder, then the head. So all these things, there are different maneuvers are also there to deliver the baby. So there are so many things are lined up when you prepare yourself for a vaginal delivery, and all other contraindication should be looked after, whether this can be subjected to vaginal delivery.
Thank you, sir.
Since we are trying for vaginal delivery, I'll just like to add a very practical point. I have not delivered many breeches vaginally. I must have delivered some, say 7 to 8 till now. But I think the most important part one has to remember is you always keep a dry sheet with you. So when the trunk of the baby comes out, it is to be supported with that dry sheet, because baby is covered with vernix and most of the times it slips from your hand, and then it is difficult to maneuver. So always hold the baby with the dry sheet and not with the bare hands, and always try and keep the maintain flexion of the head by giving a suprapubic pressure, or like the flexion, rather flex head is easier to deliver rather than an extended head. So assistant always has to keep a suprapubic pressure, to keep a flex head. And I think these two things make breech delivery very easy. Easy because at least you can manage it in your nursing home.
And if you are following the Dhatu-Chini-Andrus score, the score, if it is 0 to 4, you should not give a trial to the vaginal delivery. That is what the score
Not
says.
true.
If it is a more than 4 and onwards, then you will have to, you can give a trial keeping everything ready. That is the basic things for a breech delivery. Then different maneuvers, whenever you will come later on, we can talk about that.
Shailendra, my question next to you is, what would we do so that we don't get stumped like this? Are there any measures we can take so that, we are not caught off guard like this, right, when the patient comes fully dilated in the labor room? Any care or some precautions or some guidelines that you would like to tell us, or your thoughts about breech delivery?
See, if she is an unregistered patient who has come at the last minute fully dilated, then what Swarupa said, what Senapati sir said, absolutely we go ahead with normal vaginal extraction. Just one more point I would like to add to the previous speaker's point is, instead of a conventional lithotomy position, if we can convert into something like a macropod position, like what we do in shoulder dystocia. So we remove the legs and we hyperflex at the hip, and with continuous suprapubic pressure to keep the head flexed and the baby being wrapped in a dry towel, the breech extraction, and with a good episiotomy, the breech extraction should not be a problem. Now, if she is a booked patient, if she's a registered patient, and if she diagnosed breech, then obviously she would definitely, if she's a primary, definitely going for a cesarean section. But even if she's a multi, I would be having my doubts in conducting a vaginal delivery of a breech extraction.
Okay.
So another point I want to highlight here, because these are the things which in the foreign UK or RCOG guidelines, they say the external cephalic version of a breech patient who are registered beyond 37 weeks, not in labor, you can explain and tell the patient. I don't know how many people are comfortable about doing the external cephalic version, which has got his pros and cons about it. But I think in India, many people, or most of the people, they don't go for the ECB. But when you take a consent in the UK or RCOG guidelines, it has been seen that you have to advise that, and if it is deferred, then you will have to explain about the complication of seizure or the vaginal delivery.
Sir, but may I add, with the definition of modern obstetrics, like most of the forceps, the mid cavity, high cavity forceps are outdated. How many of us can do ECVs?
That is the RCOG guidelines, the green top guidelines. It is there.
No,
So
guidelines maybe on one
they
thing.
Are following it. This green.
If I'm allowed to speak, I just interfere for a moment.
Yes, ma'am.
Yes. As a postgraduate student in Sassoon Hospital, maybe 33 years ago, we have done successfully external cephalic version, and it was a part of our routine learning, So all of us have done it very successfully.
But madam, today you still do it?
Yes, we, whosoever, see the guidelines I'm not talking about, but given an informed choice to the patient. I would suggest that even the patients want to say that, madam, it's a breach, so will it remain like this? Do I have a chance to deliver vaginally? So these are the women where you can definitely, with informed consent and informed counseling, you can do this procedure. And if it succeeds, well and good, but still you have to give them a word of caution that even though it has succeeded, it's not sure that you will deliver vaginally, because there are so many other factors which are considered for normal labor. And if it fails or she declines, then of course we are free to go for cesarean section. So that's what from my side. And one more point, when you were talking about the delivery of a breech, all of you discussed it very nicely that you have to, not to give unnecessary traction and cover the baby and keep the head flex, only to maintain the back anteriorly throughout the labor and delivery process. I think that's all from my side. Thank you.
I think what Madam told, I was telling the same thing. 30 years back, when I was in Grand Medical College in JJ Prabha, I have also done ECG. I have done external cephalic version we have done. And it was successful and patient delivered normal. At least 8 to 10 times in 3 years of our residency, I have done it. So
in fact, for us, that was an indication, we used to discuss when you have a RH negative pressure, when you're
Yeah.
doing the external cephalic version, that is
You
an
give
indication.
NTD.
Then you should
Give
give
300
anti-D.
microgram of anti-D.
Of
And we've
NTD.
done it lots. Okay.
Yes, yes, absolutely.
Dr. Supriya, I would like to add one
Yes,
point.
ma'am. Yes, in fact, I was going to put the next question to you only as our expert.
Okay, okay.
In addition
Sorry.
to your comment, my question is that if we have a patient who is full-term vaginal delivery, waiting for a vaginal delivery, would we be, should we take the risk of inducing such a patient or augmenting such a patient?
1 minute. I'll come to your question little later. Let me just
Yes.
finish what I wanted to speak. I just wanted to add to the point what Dr. Jai and Dr. Sneha told. Whatever these kind of ECV and all that has become very, very less number nowadays in our safe practice because of whatever, let us not discuss the medical legal or whatever, but in abroad like US, where it is more of a maternity service by the nurses and the paramedical staff, it is more because the proper obstetrician is not available there at the many of the times, and only if it is an operative delivery there they come to picture. So they try to make it these kind of cases vaginal delivery as far as possible, so that it is possible from nurse's hand, so that the doctor doesn't have to come. So they take compared to us, they go to a more a serious extension, like they extremely push themselves. I feel we are not that doing to that
Brutal.
extremity.
Yes.
Yes. That is one thing. The second thing, in a breech delivery, the other thing, the back anterior, then flex suprapubic, the pressure suprapubic, etc. Another thing is you should allow for the gradual dilatation of the cervix, because most of the times it may happen that till the neck it has come down with say around 7-8 centimeter dilatation, and then the problem starts. So it is the dilatation of the cervix which is very important, so that the after coming head is easy to deliver. Now you can put me your question. What are the factors? Is this the question to me?
No, ma'am, I'll come to that question later. This question I'll put to Madhumita. What are the factors to be taken into consideration before we decide that we will go for a breech delivery? Dr. Madhumita, are you there? Dr. Madhumita, Dr. Kranti?
Ma'am. Yes, ma'am. Ma'am, actually, during our residency, we would have ECV, as ma'am has said. I was under Satoskar ma'am's unit, so very liberal ECV practice. But prior to that, we would get a sonography done, which would tell us about the baby weight, expected baby weight, then the back position, back anterior. Then we would have the flexion of neck, the degree of flexion of neck. And am I audible?
Yes, yes, you are audible.
The flexion of the neck and any other prior, like if there's a scarred uterus or something, we would not venture. So the back anterior flexion of the neck and the type of footling presentation or a complete or type of breech. So these parameters were taken into account. Then second thing is that membranes are the dilators. So we generally don't rupture the membranes, and patient is till the breech climbs the perineum. If membranes are there, it's almost we say that climbing instead of the crowning. So when it comes and climbs the breech, that is the time when we give episiotomy. If we rupture the membranes, ideal time. And then we are ready with Buscopan or Valethamate bromide injection to prevent the closing of the aftercoming head. When the aftercoming head comes, before that we used to instill one epidosin or Buscopan injection, so that aftercoming head is also easily delivered. But the rest of the things were covered, that keeping the back end, and we always would take an informed consent of the patient in the antenatal period itself, so that when patient is ready only, we give her a trial. Otherwise, it is a planned cesarean as per her choice, giving her all the pros and cons.
But I think
Supriya, you are muted.
Can I say something?
Supriya, you are muted.
Can I add?
Supriya, you are muted.
Supriya, please.
Supriya, can I add?
Yes, please, ma'am, please. Yes, ma'am, Bharti ma'am.
Well, Dr. Supriya and I agree with Dr. Shailendra. Yes, 30 years down the line, all of us, especially in institutional deliveries, patient comes fully dilated, we would do a breech delivery. And my thesis was fetal outcome in breech deliveries. But I think in today's scenario, in the private setup, let us accept it, we are practicing defensive medicine, and
Not only that, the patient, even in a primary or a multi with a normal cephalic presentation, wants a cesarean on demand. So of course, to have a breech delivery, we need to have the training. We need to have a full team with a neonatologist and anesthetist on board at the time of the delivery. Our staff need to be trained to give us proper suprapubic support, and along with that, the patient's consent and the neonatal morbidity and mortality we have to take into consent. So I think in the present scenario, yes, if she comes fully dilated, she's a multiparous lady, we have done an ultrasound, there's a good flexed head, and there are no extension of the arms, and there are no other comorbidities, we could always take informed consent, talk to them about all the eventualities, and call for assistance from one of your senior obstetricians and gynecologists who has conducted a few breech deliveries. Neonatologists standing beside you, you could always attempt the vaginal delivery, assisted vaginal delivery for this particular woman. But if she comes in the antenatal period at past 37 weeks, external cephalic version in the present scenario in a private setup, I would definitely not do it.
Yes, ma'am. Very well said.
Yeah,
Okay, this next question I like to put to Rekha madam, who is also our expert. Madam, would you think of doing a induction in this kind of a breech, full-term breech patient, or in case the progress of labor is slow, would you recommend that we augment it, or should we straight think of a cesarean?
No, I will not induce this patient, but if she comes like what you showed in the beginning, like halfway through, and if everything favorable, yes, I will wait for the progress of labor and see how she is doing. If everything is favorable, having an assistance and all the things, whatever mentioned, like check for the weight of the baby and all the risk factors, I'll give her a vaginal delivery. If everything is totally favorable, but definitely induction is a strict no-no from my side. I don't dare so much.
Okay, thank you so much, ma'am.
In fact, I would just say that it is not recommended.
Correct.
For a breech presentation,
That is what
induction is absolutely not recommended. Yes, if you have the patient already in established labor with all the factors favorable, and you feel that maybe with little augmentation she may deliver uneventfully, then there is a place for it.
Because the augment, what madam told, the induce, that is, you can't do it. You should not do it. And for augmentation, why you are supposed to augment? Because there are different types of breech are there. The footling, kneeling, these are slow dilator. They need some extra force for the dilatation. So in that case, it will be always better if you can augment on those cases. So augmentation is definitely is on the card of a breech delivery. And if then the delivery of different levels, that will be discussed later on.
Yes, sir. So Bharti ma'am, there are these various techniques that we do the breech delivery. I would like you to talk about what are the difficulties that we may face when we are delivering a baby by breech.
One is if the breech is not a complete breech, you have a footling or you have a kneeling, the descent of the breech itself may be difficult. If it's a complete breech, it is quite easy. The breech just slips out, but you have to make sure that you have the back to the facing you, the back facing you, and avoid slippage by covering the baby with a dry towel. And of course, giving proper suprapubic pressure is very essential, because difficulty in after coming head is most often what the difficulty we face. And the other thing is extension of the arms. When the arms are extended, we do have difficulties in the descent of the breech. So in case the legs are extended, we have to slide our hands along the thigh and flex at the point of the knee and try to bring down the footling. So that is what we will have in extended legs. The second problem is when we are having extended arms. So we have to do the Lovset maneuver when we have to rotate the trunk once anteriorly to the lateral side and slide our fingers and try to flex the arm and bring it out gently without causing any morbidity. Rotate the trunk to the opposite side and try to deliver the other arm. So once the arms are out, you leave cover the baby and just leave it to hang for a few seconds, and proper suprapubic pressure is to be given by your assistant so that the flexion of the head is maintained, and then by the you deliver the after coming head by either the MSV technique or the Marshall-Burns technique.
Thank you, ma'am. Thank you very
Actually,
well.
I will want to add here.
Yes.
Because in the delivery of the after coming head, there are also so many maneuvers are there. At present, we are using shoulder jaw flexion and shoulder traction, which is Mauritius Melly effect. But if olden times it was Von Marshall, we sway around the whole of the body to the abdomen of the patient. But there is a crystallar maneuver is there. There is a Wiegand-Martin maneuver is there. There is Piper forceps are there. There are Prague maneuver here. If it is occipital posterior, I will deliver. This maneuver will not work. So you also, if you are doing it, that maneuver you also should, because chin will go and fix behind the symphysis pubis. So how you will dislodge, how you will rotate 180 degrees, that Prague maneuver is also there. So because these maneuvers many times, one maneuver might fail. So you can try for the another maneuver for that. So there are 4 or 5 maneuvers are there for the after coming breach of head. And the most failed maneuver, whenever everything failed, only the Piper forceps can deliver. That is my personal experience, what I can say. And the Piper forceps and outlet forceps, the difference is this forceps blades are a little bit longer because you never know where is the head, because head it might be a little bit +1. It cannot be +2 or +3. So you need a bigger blade to catch hold of your head. And at the same time, you will have to lift the body's trunk and the leg up so that you will have enough space to put the forceps. So everything, all the maneuver fails, the Piper forceps will never fail. It will deliver you.
Thank you, sir. Thank you. We'll quickly now go to the next case. Dr. Deepa, would you like to take this case? Dr. Santosh is here. He's been waiting for his turn. So I think we can take this case with Dr. Santosh. Dr. Deepa, would you like to proceed?
Dr. Santosh. Yeah, sure, Supriya, thank you. So this is case 2, 34-year-old second gravida. Case of gestational diabetes, comes in labor at 37 weeks of gestation. On examination per abdomen, 36 weeks, cephalic, 3/5 head palpable, FHS 148 per minute, regular. PV cervix is 2 centimeter, fully effaced. Labor progresses normally, and after 6 hours, she is per abdomen 36, cephalic 0/5, FHS 136, PV fully dilated, fully effaced, vertex at perineum. After 20 minutes of full dilatation, the head is delivered, but shoulders are stuck. So, Dr. Santosh, the nightmare, how you are going to deal with it now?
This is one of the biggest nightmare of any obstetrician. But since the history is pointing towards the possibility of facing a shoulder dystocia because of diabetes, the obstetrician should be ready to face if at all it comes. At that time, the first thing one should do is to call for help of the staff in the hospital. Extra staff will definitely be required in this case, and immediately call for help of anesthetist, neonatologist. In fact, for this case, they should be standby and be there in the OT to face the situation if at all it comes. And regarding management, the episiotomy should be a very generous episiotomy. There should be a complete flexion of the thigh, and we can try doing McRoberts maneuver by hyperflexion of the thighs as well as suprapubic pressure. The suprapubic pressure should be in correct direction, assisted by the staff, and a gentle pull from below to deliver the baby.
Any other maneuvers, anybody else?
Apart from this maneuver, you can have a corkscrew maneuver over this Wood's corkscrew maneuver, where you will supposed to rotate 180 degree and get the anterior shoulder to the posterior. That is because there is a lot of space in the halo of the sacrum. So you will get a ample space there because the anterior shoulder is lodged behind the symphysis pubis and can't deliver the posterior. So you rotate and deliver posteriorly, the other shoulder will deliver automatically. That is the corkscrew maneuver you can do. And if it is not still not possible. So you can, there are destructive operations are there. You can do a symphysiotomy, you can do a clitotomy. But apart from that, there is another maneuver known as Javanelli maneuver. And that is the last resort. You just push the head back and do a seizure and remove from the cesarean section. But I don't know. I have not done till now this Javanelli maneuver. Whether the baby will survive after all this maneuver and manipulation, then you will wait and do a seizure and get a live baby. So these are the things you can do.
Thank you, sir. Kavita ma'am can take the next question.
In most of the times, hyperabduction and hyperflexion works. Hyperabduction and hyperflexion, that macrobus, and before she delivers, we give her an episiotomy also. If we see the turtleneck sign, whether there is withdrawal of the head, then we should actually anticipate shoulder dystocia and take her up for emergency section.
Actually,
I have
Dr.
just one thing to add here. I had an unfortunate incidence of delivering a IUFD. In this case, it was a diabetic patient and suddenly came with IUFD. Since it was IUFD and she landed up with, gave her vaginal trial, landed up with shoulder dystocia, and macrobots did not work. So I frankly didn't know what to do. But that time I had tried this knee chest position, and somehow it worked with extended episiotomy. And I was lucky that I did not have to subject the patient for cesarean for IUFD, but we could deliver her with in knee chest position. So I think that can be kept as a backup if macrobots doesn't work.
For this thing, I will tell you a story, because in medical college, the story is like that. There is a IUFD, as Swarupa has pointed it out. So when there is a IUFD, and this was a FSP, it was not a FSP, it was a MSP. They thought it is a IUFD of FSP. So when they are trying to deliver a big baby, what happens? It was because of MSP, they pull so much, they put so much force to pull it. The head was on our hand, and the body is there inside. So now what do you do? So there is a phone call for me. What to do, sir? Now it is inside and the head is outside. So there is no reason you will do a seizure and remove, because when the whole of the body is inside, you can't pull it. And the MSP, whatever you are trying to pull, it will be in your hand by pieces. So we did a seizure. Then what to do? How to sew it? Then the head was sutured to the neck with the catgut and everything, and then we talked to the patient and sewed it to that. So it can happen in the aftercoming breach of head also. It has happened once. I was in a lecturer at that time. I think I'm talking about 96, 97. It was again a FSB. I was just pulling it. The body came out and the head was inside. So then it is a problem. So one time I could deliver with I took a sponge holder, then Dulcelam, then I could catch hold of the head and deliver. And one time we couldn't. Then we have to do a cesarean section to deliver the head also. So such thing, because the obstetric is so unpredictable, you never know what can go wrong where.
Correct.
So you will have to sometimes apply your common sense, how to and what to do.
Actually, have you tried bilateral episiotomy for shoulder dystocia? It really helps.
Oh, that's a nice point.
Yeah, because normally for my patients, I do it so that you can put full hand inside, and it really helps. Means you can rotate the baby, and it really helps.
That is what is Jyoti. That is the reverse corkscrew manner. What Dr. Senapati was talking
Actually,
about.
it really
Corkscrew, the reverse corkscrew.
Reverse corkscrew.
That's ample space on either side. You can put whole of your hand, but then that works actually. This rotation maneuvers definitely work wonderfully. Only one message, I will not take much time from here, because shoulder dystocia is unpredictable. all of us usually think that large size baby, diabetic mother. No, why we have to be well versed with such cases and tackling this situation. Sometimes even for an average size baby, this can happen, and that's a very reason all of us should be well versed with these manuals. That's what the message from my side. Thank you.
Very well said, madam. In fact, for when I had made a presentation on this topic, I had made some papers I had read. And there are several papers which say that even average size baby can land up with shoulder dysphagia. In fact, that was used as one of the defense in some of the litigations, that when the patient says that if it is a huge size baby, why you tried for vaginal birth? Why not do a cesarean section? So this defense was presented that it's not necessary only that big size babies will have shoulder dystocia. Even average size baby can have a dystocia, and therefore not always we are justified in doing cesarean. That's how the defense was.
Supriya, in this situation, we will not be protected. When you have a large size baby, that is definitely a point where you have to warn and counsel them and take an informed written consent.
Very true.
If it is the other way around, definitely that will help.
Yes.
Thank you.
Okay, Dr. Madhumita will take the next question. Are you there, Madhumita? Madhumita, madam? Kavita Banwal, ma'am, is here?
No, Dr. Madhumita has gone for some emergency.
Okay. Kavita ma'am is here. She was busy with another webinar.
So I think she is busy with her own webinar.
Okay. Then I think anyone from the panel can take this question. That what are the guidelines? Is Dr. Nageshwari here? Nageshwari informed that she was going for an emergency, so she will try to log in. I believe she is also not around. Nageshwari is also not here, I guess. So would Bharti madam take this question, madam? What are the guidelines that we should do, we should follow when we face a situation of shoulder dystocia?
Yeah, thank you, Supriya. One is always be ready to call for help. Not only your colleagues, even your staff. You need extra staff from the OT. You need the anesthetist, so please call. And then give a generous episiotomy, and preferably, if you find it difficult, you can always do a bilateral episiotomy. And then, of course, the Macroberts maneuver, which we have said, or the corkscrew maneuver can be tried, because we have to be quick. Abduction, hyperflexion, and suprapubic pressure should be given. And then we go for the internal maneuvers or the corkscrew Woods technique and try to deliver. And you have somebody there, I'd like to add on, somebody there outside the labor room while you are delivering the baby, counseling and explaining to the attendants of what's happening. I think we need to keep them informed of what's happening.
Absolutely, madam.
And document the procedures. Document the procedures you are doing, because as Dr. MC Patel always said, if you document, you do have some defense. If you have carried out the maneuvers, which are what is pertinent in the situation, then that will be your defense in case of a medical legal problem you will have to face.
Very well said, madam.
Yeah.
Sneha ma'am has already made her comments. Would Rekha madam want to make some expert comments? Rekha ma'am? I guess
I think she's not there.
Yeah. Okay, so this is just like a flow chart which more or less describes what is the management of shoulder dystocia. And I think we'll again now proceed with the next case. Dr. Deepa, if you can just read out the case, and then maybe I can take it further from there.
Third case, 37 years old, second gravida, previous cesarean section for fetal distress. Presented with labor pains. There are 2 to 3 contractions every 10 minutes, lasting 30 to 40 seconds. No scar tenderness. Cervix 6 centimeter, fully effaced. Vertex at 0 station. At full dilatation, there is severe bradycardia. Vertex at +1. More than average bleeding seen. No contractions. Full bladder, catheterized, blood-tinged urine. What is the probable diagnosis?
Supriya, I think this is a rupture uterus. Enough is talked about.
Actually, I was going to say that. So,
Dr. Patel
has there. So, any quick comments that our panelists would like to make, then we can immediately go to the next case. Any quick comments? Patel sir has made a very beautiful presentation on this topic, so we'll not spend more time.
In details, yeah.
Yeah. But anybody, any of the experts, if they want to make a quick comment, and we can then proceed with the next case.
The most important, if any junior people has just joined in, so how to diagnose clinically, that is very, very important. Because many times it so happen it is misdiagnosed. Okay, whether there is a rupture or not rupture, the fetal distress is never also picked up. The fetal parts are well felt when sometimes the baby delivers through the rupture scar and outside the abdominal cavity. The contour of the uterus has disturbed. So all small thing, these people should know to diagnose whether there is a rupture of uterus or not. Because sometimes it so happen if there is a scar uterus and there is a rupture that we call the silent rupture. And because of the fibrosis, there might not be enough of bleeding that the vitals will change. The vitals maybe remains the same, but other things will there might not be classical hypotension or tachycardia or hematuria or all these things you may not get. But other things you should keep in mind for diagnosis. Because if you diagnose, then only you can go for exploration and subsequent management. So diagnosis is very, very important for a scar rupture, uterine scar rupture.
Yes, only one comment from my side after Dr. Senapati. Not necessarily that, the patient will have severe that cutting pain, and you may not even have the scar tenderness as it is seen in this case. So not even the catastrophic presentation, you can have a silent rupture as well. And what you have to be, you just have to have a very high index of suspicion because you're managing this VBAC. And all the time you have to see what Dr. Senapati has discussed. Here, the patient definitely has hematuria, so that is clear cut in favor of here. But the patient who was having pains previously, a scarred uterus, and now the uterus is relaxed, that is a pointer towards, that's a red flag. Thank you.
Yeah, and exactly, ma'am.
And
when
recession of the head.
Yeah, when the descent of the head, we can feel per vaginal, suddenly the giveaway sensation and there is hollowness. So that is one point that we see on per vaginal examination.
And the fetal distress is very, very important in these cases.
Yes.
Because
Sudden
the
bradycardia.
Sudden bradycardia will be detected and there will be then there is no heart instantly once it gets opened. So that is to case the bradycardia, and that is the right time to do a operative intervention, and you can save the baby as well as the rupture.
Yes.
And
sudden cessation of contractions, and if the baby is totally expelled, it's entirely a different contour that you feel of the uterus and the baby separately.
Yes, ma'am. So we'll now quickly proceed with the next case. This is a primigravida, 37 weeks in, who has come in early labor. Normal vitals, her contractions are there, say like every 4 minutes, she's getting one contraction lasting around 25 seconds. She has a very high floating head with on admission, the FHS is very good. And suddenly you find that either the FHS has suddenly disappeared or it has dropped dramatically. Either it may be associated with gush of liquor or even sometimes without the membranes actually being ruptured. What do you think would be the diagnosis in this case, and how will we manage? So Santosh, would you like to take this? Santosh?
Supriya, before Santosh could answer,
yes, sir,
this is exactly when we were students, third MBBS students, and in Wadia, our Manju Mathalia madam, she had just mentioned a very similar case, and she had mentioned that even if she's a primary, you should have the diagnosis of ruptured uterus in your mind, because many a time the patients have a previous history of MTP, and the MTP, it has probably perforated at the time of the MTP, we sealed on its own, but now it is ruptured in labor. So this is one point which I would like to really, for benefit of the juniors, that please keep in mind that even in primary, because most of the time the history of MTP is concealed, patients don't convey to us that they have undergone an MTP. So they might have had MTP, they might have had a perforation. So they always have a diagnosis of perforation, uterine perforation or uterine rupture in labor when something like this really happens.
Okay. Santosh, are you there?
Is this abruption?
Actually, yes, abruption can be one of the diagnoses, but Here what we are actually, that is why I mentioned that it can be associated with gush of liquor or even without it. But here we are trying to point towards a diagnosis of cord prolapse. So we want our discussion to basically go on cord prolapse. So, Santosh, would you like to talk about the various types?
Just to interrupt you here, only because you are saying, the uterus, because you are giving the description as the uterus is having mild contractions.
Yes.
So for abruption, you should have that woody hard uterus.
Tense uterus.
Tense area. So this is a
Tense uterus.
pointing towards.
And head floating.
Yeah. So anybody would like to take this? Maybe, yes, Santosh, please continue.
So should I okay.
Yes, go ahead, sir. Go ahead.
So only thing is that in the cord prolapse, the most common thing which we will miss, because what is the difference between a cord presentation and cord prolapse?
Yeah.
Okay. So the cord presentation, when membrane is intact and you feel there is a cord, that is a presentation. Once the membrane is ruptured, so there is a different variety of cord prolapse occurs. So what you have mentioned here, there is a covert or occult cord because the cord is besides the presenting part. Second, the cord is in the vagina. And third, the cord is outside the vulva. So these are the things which can occur in the cord presentation and cord prolapse. But the cord prolapse, you will get in a busy labor ward, in an institution, such cord prolapse can occur. Because there are so many patients in labor, you just did a ARM and went and somebody come and see the FHS is having a in a downtrain or there is a bradycardia. When you do a PV and the cord is behind, cord is in front of you can feel then whether the pulsation is there or not. Then you push the presenting part up. Then ask the other people to keep ready for the cesarean section and take the patient to the OT. But if there is a cord prolapse somewhere in the interior and come to the institution or tertiary center, by that time you will get a dead baby, because the presenting part is will be pressing over the cord, and there might be vasospasm of the cord because it is exposed to the air also. So all these things are keeping in mind. Cord prolapse is also an accident. What somebody told, it is an accidental hemorrhage. So this is also an accident, cord prolapse. So it should be properly diagnosed in a proper time, and proper intervention is required to make the baby to survive. So that is all about cord prolapse.
Correct. Santosh, once we have diagnosed, how would we proceed with the management?
Cesarean section as early as possible if patient is in early labor. So the anesthetist should be immediately called upon, and you can try to keep the head as up as possible, maybe by maybe filling a bladder, or you can just manually push the head by fingers in the vagina, shift the patient in the OT. If possible, if the FHS are fine, you can think of giving a spinal, otherwise general anesthesia is better, so that you can deliver the baby as fast as possible.
And
has anybody tried amnio infusion or use of tocolytics?
No. See, if I'm writing a paper in my MD exam, I'll write all those things. But if I'm sitting in my OT or in my labor room, I will not do such daredevil acts.
And sometimes it so happened that the patient is almost 9 to 8 centimeter and suddenly cord came out. If there is the length of the cord is too much, suppose the average length is around 50 centimeter. Sometimes it can go up to 110 centimeter. So sometimes it is fully dilated, the cord has gone and the FHS, you can deliver vaginal. Not that case, such patient you can take because the time you take to do a cesarean section, by that time she will deliver.
Yeah,
so at the same time, for the documentation, what MC Patel said, you are supposed to, somebody should talk to the patient relative, such thing has happened. So there is a chances of asphyxia, baby will be delivered, might require an NICU. All these things you are supposed to talk to the patient.
Correct.
But this cord prolapse is another nightmare, like a shoulder dystocia.
Yeah, correct.
In fact, for this case, there is a recommendation that if the baby is alive and the patient is, advanced labor, almost in second stage or near full dilatation, in fact, deliver the baby at the earliest by whatever mode possible. Whatever way she is delivered at the earliest, maybe you can go for instrumental delivery. I think that should be good.
Kranti, can you enumerate what are the various guidelines that govern the management of cord prolapse? Kranti?
Yes, ma'am, I'm there. First of all, we should be anticipating the problem, like in case of polyhydramnios, big baby, or high floating head. Sometimes with a short cord or cord around the neck, also the head doesn't descend. So amniotomy should always be in active labor and with controlled cord, controlled amniotomy. And in such cases, if we are anticipating, it is always better to have the anesthetist, pediatrician, everyone around, so that in case a decision for emergency cesarean. And as it was earlier said, that we deposit the cord and take her up with the hand inside the vagina, so that we can feel the pulsations while we are taking her on table. In case we stop to feel the pulsations, then we proceed with vaginal delivery. Unfortunately.
Yeah, right. Rekha ma'am, would you like to make any expert comments on this case?
There is just one small word of caution to what Kranti said. Hand in the vagina, steep head low, retrograde filling of the bladder, all the maneuvers are done. But don't try to constantly feel the pulsations of the cord, because that might itself push the cord into spasm. And we might land up with the problem. So it's okay. Once in a while, you go and checking this thing. Otherwise, concentrate on pushing the head up with your fingers. That would be one.
It could, you can do one modification, that you make a mop, moisten it with warm water and use that to push the presenting part, so that, the cold exposure, which causes more spasm, which will be little less. So you can maybe try that way, that hot mop.
I think
if
I'm allowed to speak, I just
sure, ma'am. Sure, Sneha, ma'am.
Rather than making all these manipulations actually touching the cord, one is what you try and push the head up, the presenting part up. That is acceptable, giving oxygenation to the mother. But meanwhile, where everything you are going to arrange for the operation theatre. But knee chest position is one position which can actually help, to avoid touching of the cord also and the manipulation. It actually takes the presenting part.
Extensive Trendelenburg position is required, so that the presenting part will go inside and little bit head low, along with the extended Trendelenburg position, so that the presenting part will go little bit inside. The compression.
And one more comment, as Supriya said about the role of amnioinfusion. It is not for cord prolapse. Initially, you had put one discussion about the cord, the occult cord presence.
Yes.
Yeah, occult prolapse. So maybe the cord descending by the side of the presenting part getting compressed because of the oligohydramnios. So yes, of course, you have to go for cesarean section, but maybe meanwhile you can try for amnioinfusion. That is one of the options. That's all. Nothing much important.
Okay, if Rekha ma'am has any comment, otherwise we can proceed with the next case.
I don't have many comments.
9:30.
Please.
9:30.
Okay, then should we wind up?
I don't know if everybody is ready.
But whatever you do, the cord prolapse happens in a fraction of a second, and then the prognosis for the baby is dismal.
Correct. Do we have time for the next case, or should we wind up? It's already 9:30.
Just to go for diagnosis, if the head is presenting part is floating, not to touch, not to even do the internal examination, try and avoid the artificial rupture of membrane. Absolutely not, as far as possible. As soon as you go for the ultrasound at admission, if at all you diagnose the cord presentation, straightway plan for cesarean section before anything happens.
And if anybody, any people are here, junior people, whenever there is a floating head or whenever there is a polyhydramnios, if you want to accelerate the labor by doing a amniotomy, so you should do a controlled amniotomy, where you are supposed to push from the suprapubic pressure, you give on the presenting part and take a long spinal needle and just prick it. So slowly, the liquor will escape and your head will get engaged. I'm not talking. I'm not talking about if there is a cord presentation, you can't do it. You will again increase the chance of pressure of the presenting part against the lateral pelvic wall. So, but if you want to do a amniotomy, this is the right way for the patients who are having all this problem.
Okay, I think because it's 9:30, then madam, what do we do? Should we wind up?
Yeah, how many more slides you have, Dr.
There are two more cases actually. One is retained placenta and the other is uterine inversion. So maybe instead of going through all the slides, if one by one, as a just conclusion, whether any of the panelists would make their comments on retained placenta. Retained placenta.
Yes, madam, can I make? So just now I have finished my
Yes,
webinar.
Kavita ma'am, welcome, madam. Please go ahead.
Yeah, actually, placenta is mostly expelled with active management of third or tertiary labor that we are nowadays doing. But still, if in periphery or if in our part also, sometimes the placenta is adherent and it could not come out, we should give immediately oxytocin. We can give oxytocin like 10 units of syntocinon in the umbilical cord also. But still, if it's not coming, we'll gently just compress the uterus from down above and gently pull it. If it doesn't come, we can immediately explore and take out. If it's not possible, then leave it. Call the anesthetist, get some good relaxation. Then only we can insert our hand like this with the fist, and we will move like abduction, adduction, and with this, we will catch hold the margin of the placenta, then we will slowly take out. If the placenta is not much adherent, otherwise, it mostly comes out. With good relaxation and anesthesia, it mostly comes out. Only thing is that if the placenta is adherent, it will not come out, then there will be some other issue and we can go for hysterectomy also. Okay. So I think this is the best way. So giving oxytocin,
one thing I want to highlight here. The control
who are not speaking, I think we should have their inputs for the last case. I think we experts are talking too much, I think.
The control cord traction is very, very important because the next case you are talking about the inversion of uterus. If you don't know what are the signs and symptoms of placental separation, you pull too much, you will end up with the inversion of uterus.
Yeah.
And if you will not separated in start to put and some placenta you will leave inside. So control cord traction is very, very important. And what the madam said, this is the flow of the thing. So you first try with the control cord traction if all the signs of separation of placenta is shown. And if you can't see within 30 minutes all the uterotonians and everything except methergine, because methergine closes the cervix. Because oxytocin, prostaglandin, all these things you can give, methergine should not be given. Because many times for active management of third stage of labor, we give methergine and we will end up with the MRP, manual removal of the placenta.
Sir, nowadays you are not using methergine in our labor.
I'm just
we are giving oxytocin. In fact, carbetocin is nowadays available and is a very good molecule. So now we don't give methergine in our day-to-day practice.
And if after that, if you are trying MRP, so madam has told MRP, if it is still adherent, so you can thought of Increta, Eckrita, all these things you can think of that. Then you will have to take the consent of the patient that you might end up with hysterectomy, and that too total hysterectomy you might require, not a subtotal hysterectomy, which obstetric hysterectomy means. So accordingly, you will have to counsel the patient's relatives.
If I can add, there have been cases in case the placenta is retained and the patient is not bleeding. It's completely adherent. The patient is absolutely comfortable and all vital parameters stable. Then there is the role of methotrexate intramuscular. Of course, informed consent, everything has to be in place.
You mean to say wait and watch policy with the methotrexate? So keep the placenta inside. Yeah, I know.
Yes.
There are some cases reported.
And we have one ongoing also who is taking multiple doses. So we are on a constant follow-up with her. And the patients are absolutely
but multiple
stable.
doses, Kranti, are not required. A single shot methotrexate with folinic acid is more than enough. And then, of course, observation.
With single shot, sir, we don't give folinic acid, and with multiple dose, we give leucovorin rescue.
No,
and,
but what's the, see, I don't think there is a role of multiple dose. Single shot method is enough for your placenta.
It was the complete
And I
placenta.
wanted to ask you whether there are any surgical techniques by which you would remove a placenta which has we have failed to remove by normal technique. Means
Well,
any-
you can always explore, do a hysterectomy, take out the placenta, repair the uterus.
Okay.
And ILS is always there to support you.
But one thing I will tell, if you can't remove the placenta by MRP,
During the surgery,
it's likely to be adherent.
if it is if you can't remove it by MRP, that means it's a adherent increta. Even if you open the uterus, try to, it will bleed. So you will.
But it is better to open early rather than waste time.
That is there. That is the assessment of observation.
Yes, totally.
Can I make a point here? Supriya?
Yes, madam. Yes.
So simple points like if the placenta is not expelled on its own after 30 minutes to 45 minutes, we label it as retained placenta. Simple measures like catheterizing or emptying the bladder, giving oxytocin, and if at all, then whatever Dr. Kavita has said, manual removal of placenta. But if at all you have the facilities for ultrasonography in your labor room, best way is to keep your probe on the uterus and see at least at that point of time that it is not a morbidly adherent placenta. I think rather than going into all these complications, best way is to rule out morbidly adherent placenta so that you go ahead with the manual removal of placenta along with all your oxytocin, and the procedure is already discussed. Because to learn a lot from this case, because this incidence is rising so high, I think the recommendation is that even when you are doing the target scan for anomalies, that is a point of time where you go for even earlier 11 to 13 weeks, you can go for looking for the retroplacental sonolucent zone, whether it is present or absent. So you can that time label it as whether she has the
Adherent placenta.
morbidly adherent placenta or no. And if at all you know this, you can very well go for whatever. Now coming to the management, once you diagnose that it is a morbidly adherent placenta, in fact, it is a strict no to any attempt of separation of the placenta. If it is a morbidly adherent placenta, a strict no to any attempt at separation, even at cesarean section. Only when you have the morbidly adherent placenta, if at all the patient is multiparous, go for hysterectomy. If it is diagnosed, you have to go for informed consent for the elective obstetric hysterectomy. If it is a patchy adherence of the placenta and if the patient is only primary, you are thinking of the conservative management, then you have to go for what is called as triple P procedure. The mapping of the placenta, that is one. Secondly, you go for selective pelvic devascularization, and then maybe you can go for the patchy resection, whatever is adherent, as Dr. Shailendra said, and then you can suture the myometrium. So that is one of the conservative surgical management for morbidly adherent placenta. So I think the message is very clear that whenever you have morbidly adherent placenta, absolutely no. The patient who is stable, you will make her bleed torrentially and you may lose the patient. So that is what the message, very clear cut from my side. And thank you, Supriya, for giving me the opportunity.
Be watchful for placenta accreta spectrum. If there is a combination of previous cesarean section, anterior placenta, low-lying placenta combination. So be careful, be prepared, sensitize your sonologists, sensitize your OT people, be prepared. That saves a lot of your work and hardship. Mentally be prepared with this combination.
Yeah, so placenta accreta spectrum, that is a separate panel discussion presentation with me. If at all you want, I can share with you, Supriya.
Yes.
So I think the discussion will go long way. I think you can wind up.
Yeah.
Okay.
We have wonderful panelists today. I know Dr. Shailendra, Dr. Rajneesh Patel sir, who has delivered the talk. So, I mean, it is extensive and exhaustive. And Senapati sir, wonderful inputs for all the cases, I would say. Thank you so much.
Thank you, madam.
Thank
Thank
you,
you, Dr.
to
Patel,
all
sir.
my
And all the
Thank you,
best.
Supriya.
All the best, madam.
Thank you.
All the best,
Thank you all
madam.
the panelists. Thank you to all
Thank you
the
so much.
candidates.
Thank you.
All the very best for your
Thank you.
upcoming elections.
Thank you so much,
Thank
and
you.
all the best.
Thank
Thank
you,
you,
madam.
MC
Thank
Patel
you
sir,
so
for
much.
the opportunity.
Thank you, Patel,
and
sir.
big
So,
round of
Patel,
applause
sir.
for the
big
entire
round of
everyone.
applause for both the
Sir, let us
moderators.
speak. Yeah.
Thank you, sir.
Supriya,
Good night.
Yes, sir.
big round of applause for both the moderators and all the panelists, making panel very interesting.
Thank you so much.
Thank you, sir. Thank you.
Good, good.
Dr.
Thank you.
Supriya, you covered all the cases and that
Thank
too
you,
on
sir.
time.
Yes. So on behalf of Happy Learning family, thank you all for joining this and supporting this series. And please bless all the candidates who are going for Foxy Endeavor. I mentioned in my
All
beginning
the
also.
best.
Yes.
Thank you.
So Sneha,
Thank you.
Thank you, sir.
Thank you.
Bharti, Jyoti, Kalpana, Suman, and
Kavita.
Kavita.
Definitely support, and
Thank you. Thank
they
you very
are
much.
going.
Thank
They
you.
are
All the
going
best.
to
and
win.
good night.
They are
Yes,
going
Thank
to
you,
win.
sir.
they are hardworking lady persons.
We will
And-
come soon for party.
Yes.
Yeah, sure,
naturally,
sure. Very much. Sure.
Naturally.
Thank you so much, everyone.
Thank you very
Thank you.
much.
Thank
you,
you.
everyone.
So
and
we
good night.
can
Thank you.
conclude now. No
Thank you.
issue.
Thank you
Thank
so
you,
much,
Patel
sir.
sir.
Yes.
So giving us the privilege for to take part in this seminar, and many more seminar you are going to conduct. So
Yes, yes. We are
possible we can.
always there. We are
Yeah.
always there.
Yeah,
Today
yeah.
is 155th seminar, so I think it's a wonderful landmark seminar for all of us. And thanks to Corona team for giving us the digital partnership. Thank you so much.
Thank
And
you.
I think
Dr. Jai, you did wonderfully. Your contribution was very good, as well as
Yes.
Dr. Shailendra.
Everybody,
Thank you, madam. Thank you.
everybody, lovely.
Thank you.
Yes,
Enjoyed.
all of you.
All
All of
the
you.
cases were so nicely presented, and the interactions were also at very high standard.
yes. Ma'am, Dr. Senapati, Dr. Shailendra, Dr.
Will not
Patel,
let us
these are all
forget
stalwarts of
the
Thane.
Gandhi.
Thane
Yeah.
obstetric stalwarts.
Yes.
Yeah.
I know
Great.
them.
Have them
Great.
on board is a real honor for us.
Yeah,
Yes,
the
yes.
first time I listened to them and then said,
Supriya,
"Wow,
Supriya, you haven't put that important slide. I thought you would put that slide.
What Shailendra is
Which
talking
is
about
like-
is, me and Shailendra, we had made a video where we were slapping our faces. Why did you take OBGY? Why did you take
Oh. Sir,
And
I
will you
think
ever take it
OBG is a
again?
very, sir, OBG is a very satisfying specialty, I would say. Let us not
अरे
talk
मैडम
about
अच्छा
the...
खासा ऑर्थो मिल रहा था छोड़ के ओबीजीवाई लिया.
नहीं, sir.
Dr. Shailendra, who
जब-
will handle such difficult cases, it's good for the
It's a very
patient.
challenging and satisfying specialty, I would say.
I'll agree with you, madam. It is
Nilesh,
really satisfying.
All these people are there with us
Yes.
on the exclusive obstetric
Yes, sir.
platform, and I know how
Yes, sir.
they discuss.
Actually, what Bharti madam, Senapati sir, and what you say, absolutely correct. I will just the time permit. I will 2 minutes. I will recite something what happened today afternoon with me. I was just finished my case from Bethany Hospital, and I was going towards my car. Suddenly, one person came running, sir, and he just like fell at my feet and touched. So I did not recognize. So he said, no, 2 years back, you had operated on my wife. And then I remembered the history. The wife was a case of cardiomyopathy with PPH and with everything. And she was in the ICU for good 8-10 days and very poor family. So we had operated in Bethany and I had forgone my charges. So he was very thankful for that.
Yes.
And as madam rightly said, that yes, it is very
Satisfying.
It is a very,
Very,
satisfying.
very
I really felt
very
nice.
satisfying.
I really
Shailendra
felt
sir,
nice.
Shailendra sir, he would have come behind you and complimented you if you had taken orthopedics also.
Sir, I think all obstetricians can write a book on their experiences.
True,
And
madam.
it is really inspiring.
मी असं म्हणते स्वार्थ आणि परमार्थ दोन्ही आपल्याला घडतात आपल्या या प्रॅक्टिस
खरे.
So thank you, everybody.
Thank you. Good night.
Thank you.
Bye.
So much.
Sir, bye, Patel sir.
Bye.
Thanks,
Senapati sir, bye.
Yes,
Bye, bye,
take
good
care.
night.
Take care of
Good night.
me.
Thank
I'm
you,
not
Corona.
I haven't made any
Nilesh.
formal appeal, but yes, please do vote for me.
Yes, madam.
Thank you so much.
Thank you, madam. All the best.
Good night.
Yeah, thank you.
Bye, bye, everybody.
Good night.
Bye.
Bye.
Good
Good
night.
night.
I'm ending the session.
Thank you. Yes.